Check, check, test, check, color, check, test, check, color, test, check, check, test, hello, check, test, hello, check, hello, check, hello, check, hello, check, test, hello, check, test, hello.
ಚೆಕ್ 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 ಹೋಗ್ತಾ ಇದೆ. ಚೆಕ್ ಚೆಕ್. ಹಲೋ ಹಲೋ ರಿತೇಶ್, ಕೆನ್ ಯು ಹಿಯರ್ ಮೀ? ಚೆಕ್ ಚೆಕ್. ಹಲೋ ರಿತೇಶ್. ಚೆಕ್ ಚೆಕ್. ಹಲೋ ಚೆಕ್ ಚೆಕ್. ಹಲೋ रितेश और एक ऑडियो चेक कर दो भाई. NI सॉरी HIE. Check. Hello, can you hear me, Ritesh? Niranjan. Check, check. Hello. Check check. Hello, Ritesh, can you hear me? Hello, Ritesh. Okay. Hello, Ritesh. Hello. ಹೌದಾ?
ಆಡಿಯೋ ಟೆಸ್ಟ್ ಮಾಡಿದ್ದೀರಾ? ಪ್ರೆಸೆಂಟೇಷನ್ ಲೋಡ್ ಮಾಡಬೇಕು. That's it. Yeah, you just come inside and take the left and the first one. authentic. Very smart. అక్కడ
Okay.
can't open into the
HDMI. ಇದರಿಂದಲೇ ಪ್ಲೇ ಮಾಡೋದು ಅದರಿಂದಲೇ ಪ್ಲೇ ಮಾಡಿದ್ರೆ ಜೂಮ್ ಓಪನ್ ಮಾಡೋದು ಯಾಕಂದ್ರೆ ಲೈವ್ ಬರುತ್ತಲ್ಲ
ಇದಕ್ಕೆ ಹಾಕ್ಬೇಕಾಗ
ಇಲ್ಲಾಂದ್ರೆ ಅದರಲ್ಲೇ ಜೂಮ್ ಓಪನ್ ಮಾಡ್ಬಿಟ್ಟೆ ಲಾಗಿನ್ ಮಾಡಿ ಇವಾಗ ಪೆನ್ ಡ್ರೈವ್ ಕಾಪಿ ಮಾಡ್ಕೊಂಡ್ಬಿಡಿ
ಪೆನ್ ಡ್ರೈವ್ ಅಲ್ಲಿ ಬರ್ತಾ ಇಲ್ಲಲ್ಲ ಅದು ನೋಡಿ.
ಸರ್ ಬಂದಿದೆ ಯಾವ ಫೋಲ್ಡರ್ ಸರ್ ಇದು
ಫೋಲ್ಡರ್ ಅಲ್ಲ ಹಂಗೆ ನೋಡಿ ಇದು ಓಪನ್ ಆಗಬೇಕಿದೆಲ್ಲ ವರ್ಕಿಂಗ್ It's working. This is not in view. ಈಗ ಬೇರೆ ಎಲ್ಲ ಕಳಿಸಿದ್ದೆಲ್ಲ ಎಲ್ಲ ಹಾಕೊಂಡಿದ್ದಾರೆ ಇದನ್ನ ಅದಕ್ಕೆ ಹಾಕೊಂಡ್ಬಿಡ್ತೀವಿ ಫೋಲ್ಡರ್ ಎಲ್ಲಿದೆ ಬಸ್ ಒಂದು ಸೆಕೆಂಡ್ ಮೈನ್ ಅಂತ ಬೆಳಗ್ಗೆ ಕಳಿಸಿದಾರೆ
ಹೌದು ಇವಾಗ
ಹೌದಾ ಈಗ ನಿಮ್ಮ recent advances blood brain amplitude EEG that's it induction shall I send that ಅದು ಎಲ್ಲಿ ಕಳಿಸ್ಬೇಕಿದೆ ಎಲ್ಲಿ ಕಳಿಸ್ಬೇಕು
ಗೊತ್ತಿಲ್ಲ ನನಗೆ ಫ್ರೇಮ್ ಮಾಡಕ್ಕೆ WhatsApp.
Ma'am, I got it. I'm putting it on. WhatsApp ಅಲ್ಲಿ
ನೀವು ವಾಟ್ಸಪ್ ಅಲ್ಲಿ ಲಾಗಿನ್ ಮಾಡಿ
ಮಾಡ್ತೀರಾ? ನಾನು ಕಳಿಸ್ತೀನಿ. ಯಾರ್ದು? ನಿಮ್ಗೆ ಮಾಡ್ಲಾ? ನಂಬರ್ ಹೇಳಿ.
8105 8105
8105
98
98
4181.
ಲಾಸ್ಟ್ ಮೆಸೇಜ್ ಬಂದಿದೆ.
You seem looks like a zombie.
ಮೈಕ್ ಇದೆಯಾ? ಇದು ಸರ್ ಕೊಡೋದು ಬಾಡಿ ಅಂತ
Hello. Good morning, everybody. Can you all hear me? Is it echoing too much or is that all right? It's all right. Yeah. I'm Dr. Prasad Chandra. I'm one of the neonatologists and consultant pediatrician at Motherhood Hospital in Bangalore. So, Motherhood Hospital of India, we are hosting this workshop through the auspices of NMF India. So, I welcome all of you to this workshop. I know there is some small delay, small glitches, and I think from henceforth, I think we should just progress it very smoothly. Just before I start, I would like to get the audience attention here, and we can start with some introduction. And can we start from here? Good morning. I'm Dr. Prasad. Also, say some experience of yours in therapy. Yeah, we have been doing therapeutic for the past 6 years, Good morning, all. I am Dr. Ramanathan, practicing pediatrician from Philadelphia. I have a good meeting in Dr. Ramanathan. This workshop is only beneficial. Hello, I'm Dr. Deepak, one of the faculty members. I work in Apollo as a senior fellow. So, good morning. This is Ara. I am PhD student in the Department of Biomedical Engineering. I am PhD related to new energy. What is it? It's kind of this dispensing system, one of the and another one is that the oxygen has a community. Good morning, I am Dr. Kunal from
download ಯಾರು
Thank you for your enthusiasm. You are all good morning. I am Dr. Good morning. This is Dr. Ankit from Medical Center and second year postgraduate in Medical. Dr. Santosh, Professor.
Good morning, this is Swati.
Good morning, I'm Dr. Suresh Yoga, consultant neurologist at Neuro Hospital. Pretty good schooling experience abroad in the UK as well. 10 years and following year at Mother schooling as well. India is 6 years, 2 years, followed by 4.5 years at motherhood in the Hungary. Rest of you are the people who come from different organizations. I welcome all of you. Anybody who comes you change your mind after it. Thanks everybody. So we will start our presentations from now on. Great to have. And those who are virtually present, I'm so sorry I cannot allow you to introduce you because we can't see your faces. So welcome all of you. So today, I'm going to be talking on therapeutic hypothermia, overview, pathophysiology, and some of the referral concepts. I want to stress a little bit more on pathophysiology today. And there are a lot of other speakers who are talking. So wherever I think the other talks are there, I'm going to just skim through that. I'm not going to talk more in detail. Next slide. So yeah, overview, pathophysiology, and assessment. Next one. So we all know that I need a slide change of that. So cannot work with this. Bro, slide change of Anyway, I'm so sorry for this technical glitches. Delivery is supposed to be a very, very happy event. And it's not a pathology. This is what we all need to understand. It's a physiological process and it's a natural process. But we all know for various reasons it's a very stressful event. Okay, just not for the mother, it's also for the babies. Not to forget even for the families. There are a lot of anticipation as well that goes with it. And a majority of the deliveries in India are still unattended. This is a situation which we all know to a greater extent. Even in bigger towns where we go and do these teachings and create awareness, still a lot of these nursing homes and hospitals, the pediatricians are not attending the deliveries. So whatever it has to be a happy moment may turn out to be a very stressful and tragic event for these babies. So luckily for us, 90% of these babies will make a very smooth transition into the neonatal life. And 10% of them will need some sort of an assistance. And again, we have to thank God that it's such a beautiful process. Only 1% of these babies who are born will need extensive resuscitation. But if you look at the population of India, that 1% is huge. So still, therefore, the number of babies who are going to be affected will be very high compared to the babies that are born elsewhere in the other developed countries. So what can go wrong? There can be compromise. There can be compromise of the uterine and the placental blood flow, and this can result in deceleration of the fetal heart rate. Then you can have in utero hypoxia. There is infection, especially in the preterm babies, and meconium aspiration can happen. And all of these can lead to birth asphyxia. Then fetal hypoxemia, there's fetal bradycardia, there is systemic hypotension. There's so many things that can actually go wrong with these babies. And when we know that, inside the womb, the baby's pulmonary artery hypertension is very high. And in some of these cases where they don't do a smooth transition, they can continue to have a persistent pulmonary hypertension. So these are some of the things that can go completely wrong. And if you look at the statistics, the neonatal encephalopathy, I'll come to that in a bit. What is neonatal encephalopathy? It's about 2 to 9 per 1,000 live births in the developed countries. And moderate to severe HIE in the developed countries, about 1 to 2 per 1,000 live births. But if you come to developing country, or how they are describing our nations as LMIC, the low and middle income countries, it can be as high as 60%. So in some of the states, it is very, very high. And I'm very glad there are people coming from Bihar to attend. Bihar is also very high. It's very high in Rajasthan. So in those areas, so some of the areas are doing good, like Kerala. Even Goa is doing good in terms of the HIE. And unfortunately for India, the HIE happens in the low socioeconomic strata, unlike the other conditions, right? And majority of these babies are unfortunately born in a very low resource setting areas, right? Resources poor and patients cannot afford. So this is a very deadly combination, right? And when you look at it, India is such a vast country. The training and the resources are lacking. And majority, I'm sure some of these equipments, when you look at it, even when you want to treat, some of them are expensive, some of them are coming up with indigenously developed machines which can be little cheaper. More and more people start using them, things can come down as well. So well, whatever you look at it, there is lack of training, there's lack of resources in such a vast country. It is not easy to do so. So I want to drive home some of the terminologies that is very loosely used. You know, people say parental hypoxia, ischemia, asphyxia as one entity. Some people say neonatal depression. What is it basically? Some people say neonatal encephalopathy. These have very clear guidelines and very clear definitions. Why is that important? One, you cannot just keep calling all babies which die as a child, right? Because just because you've not investigated, those babies might have IEMs, okay, that is inborn errors of metabolism, and we are not checking it, right? So that doesn't mean you have to call it as a child. And a lot of times what happens, the data will be very much skewed if you don't use the right terminologies. Okay, so HIE is also common in babies who've got syndromes. Like for example, the aneuploidy, the Downs and the Purthousand. These babies, they have high incidence of HIE when they're about to be born. So when you look at all these things, you cannot just put the label as birth asphyxia or label as HIE for everything, right? So let's just decipher that very quickly. So the perinatal events, most babies born with a low oxygen, whenever the babies are going to deliver, they are born with a little bit of low oxygen. They're in a hypoxic state. And there is a decreased blood flow to the placenta. Why? There are uterine contractions, cord compression, maternal dehydration, which happens. Also, they are panting quite a bit, and therefore the CO2 levels come down, which can result in alkalosis. All these events result in decreased blood flow. And reduced placental flow, which means the baby is also getting reduced blood supply. And during these stressful times, there is increased oxygen consumption as well, both for the baby as well as the mother. Okay. Then what happens if these babies are born and if they have experienced brief asphyxia during the time of uterine contractions and while they're coming out during these stressful events, there is initial increase in the heart rate very quickly, but then it starts dipping down. Okay. Next. And initially, there will be increase in the blood pressure. Again, it will start dipping down. And then the central venous pressure will also start dipping down. This is all happening in the babies. When these things happen, there will be a redistribution of the cardiac output because the body thinks, the most important organ should start getting the blood supply. Right? And what sets in is called a diving reflex, where three most important organs, the brain, the heart, and the adrenals. So these will start getting better blood supply, and the rest of the areas, the rest of the organs will not receive those sort of blood supply. And if it is severe and if it's very brief, the blood flow diversion is hampered with a deeper nuclear structure. So if you look at the brain model, if you can imagine, the central areas where your nuclei are present, where your thalami are present, where your internal capsule is present, so those are the areas which will have end arteries. And these are the areas which immediately the blood supply will stop, right? So therefore, in a very brief asphyxia, the hypoxic event, the area that is going to be damaged is the deeper nuclear structures, which is subcortical and also the brainstem. Right? Imagine if the brainstem is affected. Can anyone tell me the function of the brainstem from the postgraduate? If the brainstem is affected, can you breathe? No. So the respiratory system, respiratory centers are located in there. So what happens, therefore, if the baby has not received the blood supply, it's not going to breathe, it's not going to cry, right? So this will result in further hampering of the hypoxia within the brain, right? Although the diving reflex is there, everything is diverted to the brain, wherever the end arteries are there, that's going to suffer. And these are all in the subcortical and in the brainstem areas. So typically, a brief HIE insult will result in areas that are damaged, which are in the subcortical areas, not the cortex, right? So as opposed to, next, if you look at it, if the hypoxia is little prolonged, right? So mothers come in with loss of fetal movements, 4 hours, 6 hours. or the CPG is abnormal, you're not able to take them for the section for a little longer time, then what happens? All this loss of the pressure regulation and CO2 vasoreactivity. What we say is, whenever the CO2 is built up, basically the babies will start breathing. If people are using the ventilators, you all know you don't want to hyperventilate these babies. Why do you not want to do it? The critical value of CO2, if you're using it in the cm centimeters of water, is less than 30. Less than 30, if your CO2 is going, then the blood supply will decrease. If it's less than 25, your CO2 values, the PaCO2 values, then almost no blood goes into the brain. It just gets into that sort of position where your blood supply is completely hampered. Therefore, in extreme preterm babies, this physiology is important because it causes, anybody? Low CO2 in preterm babies causes what? No, opposite. It causes PDA. Because there's no blood supply there. So on the contrary, if the CO2 is very high, you're not ventilating properly, or if you have a bad pneumothorax, your CO2 is drastically shot up, then that results in increased blood flow to the brain that causes IVs. Right? So low blood supply, PVL. Very high blood supply is IVH. So this results in continued hypotension, and obviously with that hypotension, decreased cardiac output. Can anyone tell me what is the cardiac output? Heart rate times. So volume into the heart rate. So when there is loss of the blood pressure, the blood which is going back to the heart is suffered, right? So therefore your stroke volume is gone. Therefore, what happens? The heart, the first thing it does is it increases the heart rate, so that it needs to compensate. After some time, if this insult is continued, then it cannot hold on. Therefore, the cardiac output will start reducing. And all of us know aerobic metabolism is the best way of, it's the most efficient metabolism. How many ATPs are released with one molecule of oxygen in aerobic? Yes, 36 to 38 molecules are released. So this is one of the most efficient ways of metabolism. So what happens in anaerobic metabolism? How many ATPs? Yeah, 1 to 3. So that's the number of ATPs that is released. So it is inefficient, and therefore what happens? The byproduct of your anaerobic metabolism, it goes into the pyruvate and the lactate. So the lactic acid will build up, not just in the blood, in the brain as well. So that is the basis of why we do the SPECT MRI. I think we will discuss all that in the near future. Then anaerobic metabolism is setting in. There is no oxygen going in. This results in the failure of cellular energy. So energy of the cell is lost, right? When this continues, there is a diffuse injury to both the cortical and the subcortical area. So the first injury happens in the subcortical deeper areas where the nuclei are present, and if the insult continues and continues, then the cortex will also get involved. This is one of the ways how you can prognosticate, right? So when you look at the MRIs, and MRI discussion will also happen, when you look at these MRIs, how we know you do the diffusion weighted MRI. So that is done as early as 4th or the 5th day. That means you're not missing out any area that has been damaged, right? So in there, if you see all the cortical involvement as well, then you know the hypoxia is much more prolonged. Therefore, you can tell parents confidently and unfortunately that the outcome is not going to be good, right? So all these things is happening, and the brain is entering into like a war field. The brain is going to be like a war field. So this is mentioned as an injury cascade. So what is an injury cascade? You have an hypoxia, and you have, how we mentioned, there is an energy depletion. Okay, immediately without oxygen, the ATPs will fall. The cells are not going to function. This will result in primary cell death. There are some cells in the brain are going to just die because it did not receive oxygen and blood supply. Right? Then, if the injury continues or if the insult continues, next thing what happens is the brain will start mounting a very stormy response. And initially it starts giving increased free radicals. The free radicals are the oxygen species, the nitrogen species, and also it releases excitotoxic glutamate. Glutamate is very good amino acid. It's got a lot of functions in the brain, but if it is in very high amount, it results in a excitotoxic mode. And then it is going to use up more energy because it is in a very excitatory state, and that results in a secondary energy failure. And finally, delayed cell death. So you have a primary cell death with one insult, then the brain responds to it in a bad way because it doesn't know what else to do. There is some attack is going to happen, and then that depletes all the energy from the cells, results in the delayed cell death. So as I said, one bit about excitotoxic glutamate. This is helpful in progenital cell proliferation. It is also helpful in differentiation of the cells. It is helpful in migration, the cellular migration also. It is helpful. It's also helpful in survival. All these are beautiful functions of this glutamate, but not when it is in a very, very toxic mode. So what does this do? It will imbibe all the calcium into the cells. So the calcium which is present there, phosphorus and calcium are taken inside the cells. Then that itself sets a pro-apoptotic pathway. You all know apoptosis is nothing but suicide. So it will say that I cannot live anymore and then I'm going to start dying. And results in free radical formation and lipid peroxidation. What is lipid peroxidation? Our nerve cells are lined by the myelin sheath, which is full of fat. Right? So that is why fat is important in the growing brain to improve the myelination. And myelination helps in faster conduction. Yeah. So lipid peroxidation is basically demyelination. So it starts taking out the myelin cells, which is like go back. So all this results in widespread and profound brain injury. So brain is in a bit of a storm. So how do we make sure that we help this sort of patients? See, as I said, the primary cell death happens immediately with the insult. There is nothing anyone can do about it. We can do things like good antenatal care, good perinatal care, so attending by the pediatrician. All these things we can do. But what is happening inside is very less that we have any control over it. So postnatally, once the baby is born, can we do anything? So when I mentioned this secondary energy failure, that starts setting in from 6 hours of life. So an insult has happened now, after 6 hours, you start getting the secondary energy failure. Therefore, people who thought about all this started doing the trials. Okay, there are very famous 6-7 trials which are just summarized in here, and majority of them favored therapeutic hypothermia. Why? Because with all this storm that is going on, hyperthermia will also set in, which means these babies will become hyperthermic. That is going to cause more. If your temperature goes up locally in the brain, obviously it's going to use up more metabolites. It's going to use up more oxygen. So therefore, the widespread injury is going to be even profound, right? So, does anyone know here how this cooling started, the history-wise? How did it even occur into the medical field? So there's a lot of these people who ski in the Alps and other places, and they used to have some accidents because of avalanches and all that, and they get buried in the snow, and they were all airlifted, and rescued. Basically, when they all got better, people realized that they had a very intact survival. The brain was very much protected. But they were all in a very profound hypothermia, which is less than 32 degrees, right? And cooling started coming into the adult world, where they started using it in stroke patients, and they started using it for CA disease, so to protect the brain. And obviously, anything that comes into the adult world, it gets extrapolated into the babies as well. Because the mechanisms are very different, but the outcome what we're looking is very similar, which is neuroprotection. So all this, the cool cap, the cool cap only cools the brain, only the head. So what they realized is the outcomes are good, but the temperature, the core temperature that is assumed may not be that good. The core temperature, you can record it in the esophagus or rectal temperature. So those temperatures were not that brilliant. NICD is American, Toby is UK. Like that, there's various trials that has come in, and then they all favor hypothermia for the neuroprotection. And this is the forest plot of that, which is an updated systematic review and meta-analysis. So when you look at it, the survival has got better in both moderate and severe HIV. In severe HIV, it did not help much in terms of the outcomes at 18 months of life. However, in moderate HIV, the both survival and the impact survival were very, very good. Right? And the number needed to treat was as good as 1 in 6 to 7. That means if you treat 6 or 7 babies, one baby is going to have very good outcome. Right? So that number is very good, in fact. Right? So the next one. So it favors hypothermia for death and disability at 18 months. Then basically increased rate of normal survival was seen. Next. Then lower the death and the severity at the school age. Then number needed to treat 6 to 9 in some cases. So I just want to give one example of a baby, how we receive, right? So it was a baby who was referred from 90 kilometers away, very close to this area. And the baby had the mother had an uneventful antenatal period with a term baby boy, and the mother complained of loss of fetal movements for about 4 hours. Would you expect a brief hypoxia or a prolonged hypoxia? Based on the pathophysiology that we discussed. It is going to be prolonged. It is prolonged. Brief is very brief, like for example, an abruption is very brief. If you have intervened immediately, if you've interfered and then done a crash cesarean section, then that's brief. Even abruption, if you have not done any intervention, and if it goes on for a longer time, that itself is prolonged. Right? Go on. And there was meconium stain, amniotic fluid. We all know babies get stressed and then the meconium is released. So something is happening inside the body. Go on. CTG was abnormal. And obviously, for some reason, they refused the cesarean section. Then they agreed when the baby was born, there was a big abruption motive at the time of the birth. So you are all familiar with these sort of cases, right? So these are the ones that gets referred, right? And in this case, this baby is going to be very sick. We need to call this as neonatal encephalopathy or HIV. So when I mentioned there, HIV is hypoxia, ischemia. You should have an evidence of that, and therefore resulting in the encephalopathy, right? So wherever you don't know the cause, like if it's a syndrome or inborn errors of metabolism, and it's not fitting the right picture, you need to term it as neonatal encephalopathy. Right? This is being practiced for the last 10 years now. So if you look at any of the data from US, they term it as neonatal encephalopathy. Then they rule out the causes. Then they say it is HIV. So HIV is a big form of neonatal encephalopathy. You understand, right? So there's a clear distinction. Don't call it as HIV for everything. You have to call it as neonatal encephalopathy. Establish the cause and you refute the other causes. Right? You make sure that you rule out the other causes, then you call it as HIV. And this baby had meconium aspiration, therefore very high risk of PPHN. Even if you cool these babies, pulmonary pressures are going to be higher. The pulmonary hypertension chances are more. And this baby, if it is born in another place, we will transport. So all these should happen. When you get a phone call, you need to be thinking about all these things. Whether you can receive this baby and whether you can manage this baby efficiently. Right? So quickly, baby came out, no cry, heart rate was less, and baby was intubated. Upcasts were bad, connected to the ventilator, and then saturations were 92. Irregular breathing was present, and then the seizures. Whenever we say seizures, what is the encephalopathy? What is the encephalopathy? Is mild, moderate, or severe? At least moderate. At least moderate. So if the conscious level is very bad, it becomes severe. Right? So, correct. Next. So when you receive this sort of baby, I'll just finish quickly from here on. Antenatal risk factors should be looked at. Perinatal sentinel events, which I'm going to tell you in a minute, that should be looked at. Postnatally, when the baby is already born, you have to look at the neurological examination. and decide whether this baby fits into the criteria for cooling or not. Clear? So these are all the things that should go on. Right? Go. So lowest socioeconomic population, was there any history of placental insufficiency, whether the mother was diabetic, whether the baby is IUGR. IUGR babies are again more stressed. Okay. And last for gestational babies, if she has diabetes. No. The reason is cephalopegic disproportion is more. And therefore, chances of having shoulder dystocia is very high in these babies. So neck comes out, the shoulder will get stuck. So that's one of the primary cause of asphyxia. And PIH, eclampsia, all these are the risk factors that we need to look at. Why do you want to look at all these risk factors? The reason you need to look at these things is because you need to be prepared. So at least if you tell your obstetricians in the local area, when any of these reasons are there, you're not calling me for all the deliveries, call me for a few things. So that's the whole point about it. And perinatal risk factors are, we call it as sentinel events, which are if mother has come with loss of fetal movement, CTG abnormalities if they're doing it. Ruptured uterus is a very red sign. There is severe placental abruption, vasoplegia. All these are, the sentinel events where you should be present as pediatricians attend the delivery. You should keep in the mind that these are the babies who are going to suffer. So why is sentinel event important? In Canada, they looked at the retrospective study of about 182 babies where they labeled it as encephalopathy. 30% of cases have sentinel events. So we should be lucky to know that there is a problem. A lot of times you don't know, it just comes out and it doesn't cry, right? The sentinel events most commonly were abruption and CTG abnormalities in that study, right? Why it is important is if you know this is the sentinel time event, then I know how long it has been since the baby is born and how much time I have got to school. Yeah, because cooling is an emergency. You have to start cooling within 6 hours of the baby's life. So if mother had a sentinel event like 10 hours ago inside the tummy, and then nobody has done anything, those babies, even if after they come out, you cool the baby, the outcome is not good. So you don't take it birth as a sentinel event, birth as the timing. You have to take it sentinel event as the timing. So unfortunately for us, in 70% of the cases, we don't have sentinel events, right? And when they looked at the MRI post-cooling, it was much favorable in cases where sentinel events were known, right? Next. And follow-up of these cases, majority of the babies did very well, compared to those where sentinel events were not known. So absent of sentinel event, in these babies, they have more chances of developmental delay and cerebral palsy. So how do you assess the baby at birth? You look at the condition of the baby at birth, and any need for resuscitation or even positive pressure ventilation. The dictum of life is every baby who is born should cry. There's no other rule. Okay? If these babies started using, your help, that means there's something which is gone wrong. That itself is taken as a criteria. And usage of the drugs, any general anesthesia, or it's very common to use pethidine in places like UK, where you have a lot of babies born with depression, right? And then blood gases, you need Apgars, and yeah. See, some of the times you are not present at the time of delivery, but then people can tell you with the description you should derive the Apgars. So this is the way that we do it as well. And weight of the babies, especially if the gestation is unknown. A lot of the times gestation is not known. So minimum weight criteria, which was used in the Helix study, was 1.8 kgs and above. So at least that you should have, because if the weight is lower than that, the outcomes are not going to be good. So postnatal assessment is mainly neurological assessment. I won't go in depth of this. You need this modified Sarnath scoring. And if you look at it, this I've taken it from the NIH publication. They don't even mention mild encephalopathy there. So because usually the idea is mild encephalopathy gets better on its own. Again, there are some evidence which says mild encephalopathy babies also had MRI abnormalities. This was the study which was done. This is a Toby trial babies who were left out because it had only mild encephalopathy. Those babies, they did the MRI. almost 40 to 60% had abnormalities there. So even now we are still learning. There's still a lot to learn. And next slide. Once you do all these things, you come with the criteria for cooling. I'm not going to go in major depth. Hope that happened. So the baby should be at least more than gestation should be more than 36 weeks. There are trials which is going on from 34 to 37 weeks as well. And you assess the baby for the cooling criteria. It should fulfill at least one criteria in A, one criteria in B. And Toby mentioned aptitude EEG as another criteria. So I know in India, not majority of people are using aptitude EEG, but it is definitely useful. So we will, when we do the talk, I think we will explain that. So what was the criteria A? It is all to do about what is the condition of the baby at the time of birth. That is criteria A. I'm just taking based on the Toby here. So Afghan, less than 5, go with it. Continued need of resuscitation or bag and mask ventilation. And now the position statement from NNF has been released recently. So which says basically you all should do blood gases within the first hour of life. Okay, so that is one of the most useful things. And acidosis should be very severe. Only those babies should be considered for cooling. Acidosis severe, less than 7 pH, more than 16 days deficit. Again, if you look at NIHCD, they modified it less than 7.1 and more than -12 of the basis. So I would suggest you guys to look into the more depth of these studies and then fix a criteria. And it has to be a standard criteria only. You cannot just take it on the whims and fancies of however people say. So criteria B is all about the first criteria is condition of the baby at birth. Second criteria is how is the encephalopathy in this baby. So altered state of consciousness, abnormal tone. These will be dealt with again. Therefore, I'm just rushing it a little bit. So abnormal primitive reflexes. I take a lot of times, suck, gag as some of the good reflexes to go with, right? If a baby hasn't got those two, then you are certain that the primitive reflex is gone. So therefore, brainstem is affected. Therefore, that baby would fit the criteria in terms of your clinical exam. दिख नहीं रही है।
कुछ होश में आ रहा है?
It's not audible.
Dr. Mangal, can you hear us? Mute this thing. He's not seeing, he's not picking up the phone.
Amar, can you hear us?
Yeah. Dr. Pratap, am I audible? Hello?
Yes, you are audible.
Am I audible?
Yes, you are.
Okay, fine. Yeah.
Okay, start please.
Shall I start?
Yes, please.
Yeah, very good morning, everyone. At the outset, my sincere thanks to team Neocon 2021 from Bangalore and Dr. Pratap and the team from Motherhood for having arranged this wonderful program and having given an opportunity to be part of this program. Again, my apologies for not being able to be there physically, but hope that we'll be able to discuss a few points related to cooling today, say in the next around 20 or 25 minutes. I think we had, Dr. Pratap had given a wonderful outline of including the various practical aspects of cooling to all of you. So I'll be trying to focus a little bit on this recently published HELIX trial, which we were a part of and had a significant contribution of patients to this trial, and what we have learned from this trial and whether this trial will change our practice related to cooling or therapeutic hypothermia. Greetings from my institution, Department of Neonatology, Madras Medical College. So we, our unit has got two separate units. One is a pure extramural unit catering to babies who are getting referred from other hospitals, and the other is an intramural wing which is attached with the obstetric unit, which caters to a delivery load of around 16,000 to 18,000 deliveries per year. So both these centers were part of this trial, the intramural unit as well as the extramural unit. Quite sure that most of you would have had a chance to look at this paper published in September in the Lancet Global. So the HELIX stands for hypothermia for moderate or severe encephalopathy in low-income and middle-income countries. It's a randomized controlled trial done in 3 countries, India, Sri Lanka, and Bangladesh. So what I intend to do is, even if you have not read this paper, no worries. So I'll be just highlighting the most important aspects of this paper quickly. Then maybe we'll spend some time on, so what do we learn from the results of this trial. Where did we start actually? Our unit initially started, even before this HELIX trial, we started with evaluation of a low-cost cooling device which people were trying to make. So that machine actually was called as a HELIX Picotherm. You all know that Picotherm is one of a leader in servo-controlled cooling devices. But there are many servo-controlled cooling devices. Picotherm is one of them. Most of these devices are very expensive devices. And but servo-controlled devices are considered as the gold standard to provide cooling. Though in India, we do have a lot of other modes, especially based on phase-changing material like the Mera Cradle ones. So there was an intention and an attempt to manufacture a servo-controlled device, which will be very cheap and which will have a larger applications in low and middle income countries. So that is where we started. Again, it was a multicentric trial. So, but most of the patients were contributed from our center, Madras Medical College. It was published in 2017 in BMJ Pediatrics Open. So this was just a feasibility of a whole body cooling using a low-cost servo control device. And so this is how that device looked actually. It's a very, very compact device compared to Ticotherm. And it's just a trimmed down version of the Ticotherm, which I should say. So the various different modes were taken away. So it had only one mode, which is just like if you switch it on, it will just attempt cooling at 33.5 degrees centigrade, one fixed temperature, no different modes, no different temperatures. But it is the same mechanisms. It's a mattress-based coolant is circulated through the mattress, and there is a rectal probe which monitors the temperature. And the device did not have actually a rewarming part. The rewarming part was done manually when initially. That part was later added as an option to this device. But initially when we tested, it was not capable of rewarming the patients. But we had very good results. So this is a chart showing what is the mean temperature that is maintained for the period of 72 hours, which we are cooling. So in a short time, actually, there was a good induction. Say, within an hour or two, most of the babies reached the target temperature of 33.5 degrees centigrade. And there was no major fluctuations. So throughout the 72 hours period of cooling, the temperature was well maintained around 33.5 degree using this device as well. And then, so this was a more passive rewarming, the temperature back to 36.5 degree. So this, the end result of the study was the device was reliable. It was, and it's a valid tool which can be used for cooling babies. And but we analyzed certain clinical factors also during this trial. This was, as it was a trial only to test the feasibility of a new equipment. It was not a randomized trial. We were not randomizing babies to cooling at that point of time. So just there were some babies who were put on this device, and there were some who were not cooled. And when we looked at their clinical outcomes, actually that was not the intention of this trial, but still we didn't find a significant difference in mortality at that point of time. In fact, our cooling arm had less mortality as far as this trial is concerned, babies who were cooled. But whoever had died, again, we found a very high incidence of bleeding, especially a gastric bleeding. And that was reported in this paper. If we just look into these numbers, so babies who did not have a bleed hardly had any mortality, whereas those babies who had a bleed had a very high mortality going up to 44%. That was surprising because the gastric bleeding was hardly reported from the Western countries as an adverse event of cooling. It looked our babies were totally different, so we reported that one. This paved this initial trial, which we are part of, paved the way for the proper multicentric large randomized controlled trial to evaluate really whether whether cooling works the same way in low and middle income countries. This is a protocol which was published in Trials in 2017. We started with 5 centers, and later it was expanded to include a little bit more, the totally 7 centers. And so again, as I showed earlier, so after the trial was over, just in this September only, this trial got published in the Lancet Global. So what do we do in this trial? So in this trial, who got included? So again, the standard ages. The baby has to have a gestation of more than or equal to 36 weeks. Babies had birth weight of more than 1.8 kg, and in the first 6 hours of life. Then they should have had a documented, as we say, in the form of either a need for continued resuscitation at 5 minutes of each, or if ABGAs were available, then we have taken in 5-minute ABGAR of less than 6. And or if both of these are not available, if there is a lack of crying by 5 minutes of age, especially if that criteria was taken only for home deliveries, but we hardly had any home deliveries. So most of the babies fit into one of these two criteria: 5-minute Apgar less than 6 or need for resuscitation at 5 minutes of age. And then definitely going by a standard NACHT assessment. Sorry, should I continue? Am I audible? Do you hear me?
Yes.
Okay. So, and then with babies with evidence of moderate or severe encephalopathy based on a standard structured clinical examination, which was a modified Sarnap stage. So, I think Dr. Pratap would have discussed this NACHT neurological examination. It's just a modification of the Sarnap scoring system, but it has been made more objective. Whereas actually you just see there are various signs listed. People had to make circles. So in fact, every categories of these 6 categories, whenever baby is there, we need to just make circles, and then we just count the circles at the end to see that where most of the circles for, wherever we have 3 or more circles, that will be the classification. Reasonably, I'll say, an objective way. And just to improve the objectivity, actually the scoring was done by 2 different persons. Only when they both agreed on the level of HAE, whether it is mild, moderate, or severe, so that was taken as the final report. If they differ, then in senior was involved in the assessment of level of anxiety. Who did we exclude? The babies who are more likely to die, like absent heart rate. Please, others can you meet us? Babies with major life-threatening malformations, and as it was a trial which warranted an 18 months follow-up for measuring neurodevelopmental outcomes. So whoever is unlikely to come for back for follow-up, like migrant family or parents, they were also excluded from the trial. And the primary outcome measure was to measure, it was a combined outcome. We were interested in measuring death or having some form of moderate or severe neurodevelopmental disability. So what are the incidence between these 2 groups? That was the primary outcome measure. So this was the initial estimation done. So when we started the trial, our hypothesis was cooling will decrease the primary endpoint, that is mortality or moderate to severe neurodevelopmental disability. So based on trials from the West, so we thought that it can lead to something like a 30% relative reduction in the primary outcome. So the baseline estimated was around 50. So we thought it can go up to 35 to achieve that with the standard alpha and beta values, giving an allowance of a 10% loss to follow up. So we required around 204 babies in each group for this trial. So again, I won't be boring you with all these numbers. So this is the process that was followed, and showing, we approached something close to around more than 2,300 babies. And then we found around 576 to be eligible, but around 67 ultimately and 206 babies in each of the limbs, the intervention limb and the control group. Though we had given an allowance for a 10% loss to follow-up, there was a very good follow-up rate. Hardly we didn't even have an 5% of the loss to follow-up. So only 7 babies did not have the primary endpoint available in both the limbs out of more than 200 babies. Even after the 7, around 3 and 2 were available for their assessment over telephone. Only 4 and 5 were lost to follow-up. So we had a reasonably very good number of 195 in the intervention limb and 199 in the control limb who were assessed for the primary endpoint, which is the combined outcome of death and 18 months neurodevelopmental outcome. Okay, this is the final very important slide. So what had happened to the primary outcome? If you look into this composite primary outcome, death or disability, there was no difference between the 2 groups. You just see 50% incidence in the hypothermia group and 47%. So the p-value was not significant, RR going on both sides of 1. So saying that actually cooling did not make any difference in the primary outcome. What was surprising, or say rather than surprising, what was worrisome was, so one of a very important secondary outcome. So that is when we measure the death up to 18 months. So we had around 42% deaths happening in the cooling limb, whereas the death incidence was around 31% in the control limb. Very significant difference with a risk ratio of 1.35, both lying on the confidence intervals, lying more than 1. Whereas the difference was noticed in the disability. Of course, the reverse was true. As there were more deaths, we find less babies with disability in the hypothermia limb, and more babies had disability in the control group. So these are the major findings. I think again we will just stick to them for the time being. I'll skip the other. I just kept the table only if somebody had any questions to answer that. I kept the table. As we found in the initial pilot trial, then looking into the causes why the babies died, why was the mortality high? So you can just see the main differences were babies in the cooling limb had high incidence of gastric bleed. Pulmonary hemorrhage incidence was quite high. The incidence of PPHN was a little high in them. They had abnormal coagulation. The sepsis rate was not different between them. And thrombocytopenia was significantly different metabolic acidosis. They were sick babies. Shock, poor perfusion, abnormal coagulation, thrombocytopenia, gastric bleeding, and pulmonary bleeding. These were the main differences between the groups who were cooled and not cooled. And they seem to be the important events causing more deaths in the hypothermia group. So this is a slide showing actually what was the grade of encephalopathy. The grade of encephalopathy was daily measured for a week's time in both the groups, intervention and control. So babies moved from HAE 3 to 2, and even they moved to mild encephalopathy in both the limbs. But this is expected. I think there was no difference between the two groups related to the proportion of babies and how these babies moved, whether the improvement in their encephalopathy from severe to moderate or mild over a period of time. That was the same between the two groups. And was there a difference? Was this result due to very poorly maintained or poorly administered cooling? No, definitely very clear data from all the babies showing a very tightly regulated and maintained temperature throughout at 33.5 degrees centigrade, and a very controlled way of rewarming also. And babies, and there was a lot of measures taken in the control group also to avoid hyperthermia. So hardly any babies in the control limb had temperatures reaching hyperthermia as well. So this is a survival graph showing that the blue is the cool limb. So there was a very significant difference in terms of what to say, survival, less survival in the cooling, which continued till 18 months when we measured. The difference between the two is there throughout. There was an analysis of MRI biomarkers also between the two groups. Again, this is a little complex, so I'll just say that the biomarkers which estimate both the injury as well as the recovery, they were the same in the both groups. There was no significant difference when we look into the biomarkers between the cooling group and the non-cooling group. Okay, and a very significant proportion of babies had seizures. So around more than in both the groups, cooling and non-cooled, close to 70% babies had seizures at the time of randomization itself, and around 15% had seizures on day 1 out of the babies who had seizures. So that was a bit surprising. Very early onset of seizures, and but there was a significant drop in the heart rate again, which proves that cooling was effective in the intervention level. Okay, I think that's enough related to the data. So again, in nutshell, almost the inclusion and exclusion criteria of this trial was very standard in lines of the other cooling trials that have been done. There was a very big sample size, more than 200 babies in each limb, and all babies were assessed objectively. The inclusion was based upon NACHT classification to assess the level of encephalopathy. And we did not use the modified device for this trial. This was the actual take-home as far as the helix trial is concerned. And all babies were under continuous rectal monitoring throughout. And we had access to 3T MRI also in all these centers. 2 centers from Chennai, 1 from Bangalore, 1 each from Mumbai and Trivandrum. These are the 5 centers in India, and 1 center from Bangladesh and Sri Lanka. So why was we are also taken aback by the results showing that there was no difference in the composite primary outcome and an increased mortality noted in the cooling group. So that was very, very worrisome. So we went back and we did some subgroup analysis also to see, to understand, so what are the likely cause? So one thing was very clear, it didn't look like it is because of the method technique per se. So because it was a servo control device used everywhere, and the data showed a very effective cooling in the cooling limb and a very perfect regulation of cooling, rewarming both phases. So then comes the question, is it related to the setting or the population differences? Are these babies in the low and middle income settings inherently different, or the kind of population which are coming to these, because all these hospitals are public sector hospitals, no private sector hospitals were involved. Is it because of the kind of babies which are being referred to the public sector hospitals? So these were the questions in mind. So again, just quickly going through, stratifying the results by whether was there a difference between inborn babies and outborn babies. Most of our babies were outborn babies, nearly 60%. Only around 40% of the babies were inborn. So the trend was the same, even though inborn, it was, the results became insignificant when we just looked into the inborn group itself, but the trend was more like an increased risk of mortality, both in inborn and in outborn babies. There's no difference when we try to stratify by the birth weight on the result, almost all staying on one side. Going by the growth status, we had around 25% of small for gestational age babies. SGA was not an exclusion criteria, but still both AGA and SGA seem to have the same effect. It was not an influencing factor. Many people question whether it is because of an increased incidence of sepsis, because in public sector hospitals, the incidence of sepsis could be quite high. Again, when you stratify by presence or absence of sepsis, the results did not differ. And this is a very important slide. See, this is actually, even though this number is alarmingly different from what we see in the Western world, like only 11.5% of our total babies had some documented perinatal central event. No central event was documented in 88.5% of the babies. But that is even, leave the trial. So whenever we have asphyxias getting reported, babies getting referred from outbound units, hardly there is any documented asphyxia, sentinel event. But that is the usual kind of babies that we get, irrespective of whether it is Chennai, Bangalore, Mumbai, or Trivandrum. So that also, we're not sure whether it influenced the outcome. And stratifying by the center or the center's death rates did not make any difference. The same was found in the other for the when the composite outcome was also looked at. So coming to final few slides, so we concluded based upon our analysis, somehow look like, at least going by the various subgroup analysis, did not yield any difference in the results. So it looks like cooling is not safe in the babies who are included in the trials. It increases to more mortality. So we suggested that people should be cautious, and it is not safe to do cooling in babies in low and middle income countries. Having said that, a lot of discussion happened after the publication of this paper. Many expert comments came, and I think you all know that actually even NNF constituted an expert committee, and they did some meta-analysis, including the results of this helix trial, and they have come out with a position paper also. So whether we should be doing cooling or not, and what should be the criteria if we are going to cool the babies. So this I think have been discussed already. The helix was in line with the inclusion criteria of whether it is Australia, UK, or the US. The criteria are more or less the same. But I'll just focus what the NNF had said, and maybe I'll just my personal views on this also, and then I'll just be open for questions. So NNF had actually what they have done is that the meta-analysis done by NNF, including the helix data also, and including all the previous trials done from low and middle income countries, they found still there is a decrease in mortality after including the helix data also. So that's why they went ahead and they said that, okay, we should be cooling babies with moderate to severe HIE, but they have just brought in very, very strict, criteria right now they're advising. So what are the strict criteria? So apart from these standard more than 36, less than 6 hours of life, you just see admission temperatures, they now say it has to be between 36 to 37.4. They don't want to cool babies who are already having hypothermia or hyperthermia at the time of admission. That is one important thing which has been brought out. And now they have mandated a pH which is done either cot pH or a pH done within 1 hour of life. You need to have either a pH of 7, less than 7, or a base excess of more than minus 16. And again, some rigorous criteria related to, they are not taken even the 5-minute UPGARs. They have went ahead with a 10-minute UPGAR score of less than 5, or need for positive pressure ventilation at 10 minutes. And again, the NNF question paper has mandated a history of an acute perinatal event, such as an abruption, rupture, or a cord prolapse. Of course, evidence of severe and moderate encephalopathy. So that will, I think, to a larger extent, if you just go by the NNF's question paper, it will restrict the number of babies who will be getting cooled. Like only babies who are not neither having hypo or hyperthermia on admission, and then having a documented acidosis in cord blood gas or a blood gas done within 1 hour, 10-minute UPGARs less than 5, and with the documented acute perinatal event. These are the babies who have been found to be safe as per the NNF question paper recommendation right now for cooling, of course, with moderate or severe encephalopathy. They have who are the babies recommended not to receive cooling. Babies with apart from anomalies and genetic malformations, those with severe IUGR, already having evidence of severe coagulopathy, trauma, or intracranial hemorrhage, it is not recommended in these babies. And NNF still recommends preferring a servo control device. They say recommended servo control device should be the preferred cooling choice. But in the absence of a servo control device, you can consider other devices like gel packs or PCM material. But in that case, you should be ensuring a 1:1 nurse patient deployment if you're going to use servo control devices. So my take on this is that actually, maybe the the conclusions of the helix, or a paper that followed in IJP, an expert paper review paper following that, recommending totally that nobody in LMIC should be adopting this cooling and recommending a total ban on cooling. I don't agree with that. That's not my personal take. But definitely helix has raised a big concern about the possibility of cooling leading to more deaths in babies, especially received in extramural settings with no documented sentinel events, and which is mostly the kind of babies what we see. I'll say at least in 70 to 80% of the moderate to severe asphyxia that happens in India, they're all getting referred to public health research hospital. So these units definitely should be very, very cautious and should have a rethinking. The rest 20%, they're being done in private sectors where maybe they would have had a different kind of babies, maybe with more of acute events, documented sentinel events with better facilities. But it's now on those units to prove, document, do a registry, and come out and say that cooling is safe in those situations. And so till that time, let us go by this NNF question paper and these recommendations to play safe. And let's generate more data from India, especially more from private sectors, so that whether that data will lead us to think whether the problem was with the population or with the setting. And that's my final take. Thanks for the opportunity, and I'll be happy to take questions if any. There was one question from the chat box. You just see, was the progression from severe to moderate to mild similar in the two groups? Yeah, I showed the slide and the data, because we do know that because babies improve over a period of time, and some improve, some don't improve, but that proportion of the change in the level of encephalopathy from severe to moderate and then moderate to mild, that was the same in the cooling group and in the no cooling group. There was no significant difference as far as our trial is concerned. The data was shown in the form of a graph.
Mangal, can you hear us now?
Yeah. I hear you.
Okay, so we have a little technical glitch here. We can't hear your voice in the speakers. All the people present here, we couldn't hear the final conclusion aspect of it. Can you just very briefly tell us the conclusions?
Okay, I'm sorry for the technical glitch. So the nutshell of the presentation was, see, this trial, the HELIX trial, was a well-conducted, adequately numbered, and well-executed trial, quality control trial, but done mainly in public sector hospitals from India, Bangladesh, and Sri Lanka. So what we found was that actually the cooling doesn't make any difference in the combined outcome of death or neurodevelopmental disability at 18 months, and it leads to more deaths in the cooling limb. So that is a concern. That's why the trial concluded saying that cooling seems to be leading to more mortality, and we should do away from cooling in babies in LMICs. Definitely the settings in the public health setting and the private settings might be different. The kind of babies, as it showed in the data, like these are babies who are 60% of them were outborn, and only nearly 11% of these babies had a sentinel event documented. Around 88+% of babies did not have any sentinel event documented there. But I'll say, to my knowledge and going by my experience, so these are the kind of babies what we see day in and day out in a public health setting hospitals, which might be, rough estimation, maybe something like more than 80% of the asphyxia and the HAE load what we see. So these centers should be very, very careful. They should not, they can't undermine or take these results from HELIX easily. The rest of around 15 to 20% of the babies who are being cooled in the private sectors, again, the onus is now on these centers to just collate data in the form of a registry and to show that really actually the cooling is safe and it brings, and maybe the population is different. So till that time, I think the NNF has done a wonderful job and coming out with a question statement. Now NNF has brought in very rigorous criteria, like babies, NNF is recommending cooling only apart from the standard guidelines, like more than 36 weeks, less than 6 hours of life. These babies should not have hypo or hyperthermia on admission. The temperature should be between 36 to 37.5. There should be a cot gas available or a gas in the first hour of life where the pH should be documented to be less than 7 or base X is more than -16. And there should be a documented sentinel event with moderate or severe. This is the criteria given by NNF expert committee right now. So I'll say if your baby fits in with all, which may not be the case in many babies with HIE, only in this group, NNF had gone ahead recommending. In the other group, definitely there is a concern whether cooling can lead to more deaths. That's my final take.
Just quickly, Mangal Bharti, I know the position statement, but in your center, have you stopped cooling or are you
Yeah, we have not restarted. because our kind of babies are the same, whatever we had in the trial, or the babies whom we continue to get even today. We are just looking at our sentinel events data. It is hardly 10 to 15%. We don't get a documented sentinel event in 85% of the babies. And still we continue to receive babies with not properly documented UPGARs in our outbound unit. It is written as asphyxia, baby not cried, some resuscitation done. We don't have properly documented UPGARs and details of resuscitation. So in both our intra and extramural centers, right now we are not pulling. We are holding on.
Thank you. One last question. I don't know whether the audience have got any other questions. Anybody else have got a question? So one last question from me is about this Pondicherry study on the genetics of the Asian babies, and why they are hypothesizing that this could be the possible reasons why Helix trial showed such bad outcomes.
Yeah, I do agree that actually I don't question or their findings or observations. The only concerns are that actually, the numbers are small in the other trials, and maybe they had catered to different kinds of babies, because all their data was on intramural babies. They did not have any extramural babies. So that's why I'm just repeatedly saying that it is time for us to find out whether we do have to find out a subgroup which is going to be beneficial, and whether it can be dangerous in the other group. So that is where we are right now, to identify or find out in which subgroup it might be working and which group it may not be working. The main concern is that most of the babies in India right now, especially coming to public sector hospital, will fall in the group what we had in the Helix trial. That is the major concern. That's why we are not started pulling and stuff.
Okay, thank you so much, Dr. Mangal Bharti, for clear explanation on the Helix trial, and thank you so much for joining. We'll move on without further
Thank you. Thanks, everyone.
delay. And the next topic is about induction and maintenance of hypothermia, hemodynamic monitoring, blood investigations, and completes a long talk from Dr. Ram Prasad. Okay, thank you.
Very good morning. Very good morning. So, for all practical purposes, this is the therapeutic hypothermia and therapeutic hypothermia workshop. We believe in that one. Let's all keep Helix a little bit, and we believe that therapeutic hypothermia works, and we'll go forward today, and let's see what happens. So, so most of the centers where Sir has started, and recently a few pediatricians have started this one. Have you found any sort of problems in managing ventilation or circulation? So therapeutic hypothermia is the specific management, but supportive management is also very important. Have you found any difficulties in not extra? Anybody else? Yeah, madam.
This is very important. So, identify a basic response becomes very difficult. You can identify shock. That is the shock goes unidentified. So that will take you out.
That's what it's and Pratap was saying that the level 3 where invasive blood pressure monitoring has to be there when you're monitoring such a sick child. Invasive blood pressure monitoring, of course, functional echocardiography is also a very useful tool for managing or assessing sickness of such. So, next slide. So this was the tachythermia what we use for cooling. There is entered the cooling criteria. We use this for almost 72 hours and rewarm for next 12 hours. So till today, we all thought that it's a static encephalopathy, but in fact it's a progress with the facial damage can continue for years after. But here is the thing where we are going to introduce before the reperfusion injury starts between the primary energy failure and secondary energy failure. The Pratap was telling it is a 6 hours period where it is there, where we have to start before that secondary injury sets in. We have to start to prevent the progress of brain injury. Right? So this therapeutic window of opportunity is very important, so that if you see or if you found any HI baby at centers, that passive cooling or that Madam was going to talk, it plays very important role, because it will take at least a good half an hour to 1 hour to get the temperature from 36.5 to 33.5. So it's better, because we have to start. Most of the studies have shown that it is beneficial to start within less than 6 hours. So the child baby reaches around 5 hours, 5.5 hours, might take for the transport. So if the baby is already on passive transport, passive cooling, it will give a good result rather than getting the baby after 6 hours and we'll start cooling. It will take at least 1 hour. So next. So usually we will be talking about Sarnath and Sarnath cooling system, but one or more user is leaving classification, basic consciousness, tone, seizures, sucking and respiration. It's a simplified classification of Sarnath and Sarnath, where it's classified to mild, moderate, and severe. So just introduction now what I mean. So consciousness, a mild child, mild HIE child will be irritable, moderate and severe it will be comatose. Tone, hypotonic and mild, and marked hypotonia, and severe HIE. Of course, entry of seizures will be there with the moderate HIE, and the sucking, poor suck to unable to sustain respiration or apneas can occur in severe HIE. So it's always better to have audio visual clues when. One video, but unfortunately. Okay, no problem. Right. So coming to the actual topic, induction and management of hypothermia. It's always specific treatment. Hypothermia is very important. Apart from that, supportive management is very, very, very crucial for getting the benefits out of hypothermia. Now you are thinking hypothermia along with other adjuvant drugs like erythropoietin and all we are talking about now. But if you can properly manage the child, to properly ventilate, properly manage circulation, if you can maintain the brain perfusion properly for the first 3 days after a HI injury, along with therapeutic hypothermia, most of the studies have shown that it will yield a good neurological outcome. So it's very important to maintain hemodynamic. See, hemodynamic monitoring is very, very crucial, important, as important as therapeutic hypothermia. You cannot underestimate this supportive management. So prevention, of course, is the key to success. Ensure physiological oxygen acid base balance, correct fluid electrolyte disturbances, avoid hypoglycemias and hyperglycemias, both are injurious to brain. Maintain adequate volume and hemostasis. So usually hypothermia induction, when we have any of the servo control measures or phase control material, as soon as we receive the baby, we will start doing keeping the baby under. As long as we get a transport call, also we have to make sure that we get ready with all the servo control machine ready, because it's little bit process will be there to fill up the sheets, and you have to make sure that everything is ready. And as soon as baby reaches here, we have to start the induction phase. Induction is nothing but induction, maintenance, and rewarming phase will be there in hypothermia. So how does induction work? So specific cooling is
started within the first 6 hours of life. So Tekatar Neo and Merak credit. Only the laptop. Not working with the, it's working here. It's okay. So it started within 6 hours, we don't know. But few centers will see up to 12 hours also they are taking. But as soon as now the studies are there, 6 hours it's beneficial. 6 to 12 is still controversy. After 12 hours, we don't cool the babies usually because already secondary injury has set in. So it's very important to start in the 6 hours, maintain for 72 hours at 30 to 30.5. And it's the only proven neuropredictive. It's the only specific treatment for decreasing the brain damage. So what you have to remember is hypoxic ischemic encephalopathy, asphyxia, affects each and every organ of the body. It's not only the brain, it affects the heart, it affects the lungs, it affects the liver, kidneys, blood, everything is affected with hypoxemia. So you have to take care of entire system, not only the brain. So of course, when to start cooling? As soon as possible after resuscitation is completed. If you have in-house baby, as soon as it has started, you resuscitate the baby. Make sure that resuscitation you do with room air initially, because we all know hyperoxia is bad to the lungs, is bad to the brain, bad to each and every organ of the body because it induces free radical injury. So during resuscitation, make sure that you start with room air. But if you require, as per NRC guidelines, 100 you can resuscitate with room air, because the studies have shown that those babies who have resuscitated with room air, their neurological outcomes is more good when compared to started with oxygen. Current evidence that cooling is unlikely to start after 6 to 8 hours. So this criteria, I think the Pratap has already described all this when what are the contraindications of cooling. Yeah, passive cooling, as I said, it's very important to start cooling the baby during the transport itself, so that baby when reaches here, we will do start cooling in the programmed fashion. Because passive cooling should be initiated as soon as potentially eligible neonate is identified. You have a sentinel event, baby hasn't cried, or baby is having history of blood loss like anticordon hemorrhage or any cord prolapse. So immediately after getting the baby to the warmer, just switch off the warmer and make sure the temperature doesn't go up. So switching off warmer is one of the things what we can do in our in-house. Then you can shift to the, if cooling is available, you can shift to the servo control in this one. So this is a protocol usually for cooling the passive cooling babies. So what they will do is usually they will decrease the temperature. They will not put any warmer. They'll get the temperature to 33, 33.5. If the temperature is going below 33.5, they will wrap up with blankets. If it's more than 34 or 35, they will open the blanket. That's how they will come for the passive cooling. So this is the actual this induction phase starts at I mean, it will take good 1 hour, half an hour to 1 hour for this phase 1. Then beginning of the maintenance phase 2, and then the rewarming phase, which will take at least 12 hours, 0.5 degrees per hour. You have to rewarm. So that's what rewarming should be done slowly. Now there is one problem with rewarming is we should do fast rewarming. Then again throw seizures. So if you find seizures during rewarming phase, you get down the temperature again to the phase where baby is stable. For example, if it is 35.5, baby is getting, or 36, baby is getting seizures, go back to 35.5 or 35 again for few hours, then we have to rewarm. That's how we can control seizures. So there is increased risk of seizures during rewarming. Consider EEG. Whenever we have to do EEG monitoring, amplitude EEG, or if not available, solid ECG. Now, this Thompson score, what we routinely follow for any baby who is on total body cooling. So we'll regularly record every day for the first 4 days of the weather to know the neurological outcome. A score of more than 12 is associated with adverse outcomes. We manage, see how is the tone, level of consciousness, seizures are there, posture, morose, grasp, reflex, other reflexes, respiration, and fontanelle. We if you follow this sounds and flow daily once, we can, when the child is on total body cooling, then we can see how the neurological outcome is. So as I said, more than 12 is associated with adverse outcomes. Now, coming to the hemodynamic.
Right.
हाँ रक्षा भी खाने के लिए आया था शादी में, बहुत इतना बीमार हो गया, इसको डॉक्टर भी इंजेक्शन भी लगवाई, दो से पत्थर करेंगे इंजेक्शन तो मेरे को नहीं मिल रहा है, मेरे को तो वो तो फॉलो करनी पड़ेगी, ये दवाई देती हूँ डॉक्टर ने, ये दूसरा ये वाला इंजेक्शन लगाया था, दो इंजेक्शन लगाए थे वहाँ पे, चलो हमें गौरव बहुत ज्यादा गड़बड़ हो गई थी काफी, खांसी भी बहुत है। हाँ जी भर्ती के लिए लिख दिया था, भर्ती अच्छा भर्ती के लिए लिख दिया था, ये तो मैंने बताया था इन लोगों ने, या मैंने बताया मनाने के लिए आया था शादी में, छोड़ा गया था घर से, तो तुमने रख लिया था उसको, मामा की शादी थी ना, तो क्या करते हैं रख नहीं सकते थे ना, सगे मामा की थी हाँ 10-12 दिन में आया है, बहुत ज्यादा छाती भारी हो गया, खांसी हो गया, मैं वो जी रहा था छोले को देख देख के, हम जो बहुत अकेले थे हम दो आगे ऊपर बेटा आकर अच्छा बेटा ना बोलो बस उल्टी भी हो रही है ना इसको, खांसी खाया भी खा भी नहीं रहा कुछ भी, हाँ तो है ना घर पे नेबुलाइजर, तो आपसे पूछा था ना, हाँ तो नेबुलाइजर तो है भी शायद, ये मशीन पड़ी है ना घर पे, मशीन तो है कि हमारे पास मम्मी की लेती है ना, बेटा मेरा यहाँ बैठ कमर, ओ ये नहीं बिट्टू, बड़ा ना घट गया होगा, कपड़ों का भी वजन हो जाता है ना, इसकी माँ भी बीमार हो गई, वरना भी ये भी बीमार हो जाता है दूसरी जगह पे, ठंड सर्दी मतलब बच्चे और इतनी केयर भी नहीं होती, शादी में कौन इतना ध्यान रख सकता है, जो चूल्हे कर लेते हैं, कोई भी हो चाहे नाना के हो चाहे हो जाता है, तो यहाँ बच्चा यहाँ भी होता है, फिर कोई बात ही नहीं है, उतनी केयर नहीं हो पाती जैसे नॉर्मल, हाँ वो केयर नहीं हो पाती शादी में, नो एक्चुअली तो शादी ब्याह में इतने दिन के लिए अब जाना ही नहीं चाहिए, जिसका बच्चा छोटा हो ना 2-3 दिन के लिए जाओ, हमारी हमारी तो सोच है कि उसकी अपनी भी सेफ्टी है, हम देर के लिए चलिए, लेकिन आजकल ना ये होता है कि तुम बोलोगे तो बुरे बनोगे, अब आप 2 हो जाएगा 2-4 दिन में ठीक, कोई बात नहीं, तो हमारी पढ़ाई चल रही थी, कॉन्फ्रेंस तो वर्चुअल हो जाती है ना आजकल, मैंने बाहर जाना है कल 2 दिन के लिए, तो आज की मैंने 3 दिन तो नहीं छुट्टी ले सकता, तो ऑनलाइन उसको अटेंड कर रहा हूँ, बीच में पढ़ाई भी करनी चाहिए, तो लेक्चर चल रहा है बेंगलोर से, कल सुबह बेंगलोर जाऊंगा, हाँ हमारी ना सालाना एक मीटिंग होती है, जिसमें सब डॉक्टर फिर इकट्ठे हो गए ना 2-2,500, तो इस बार कोरोना के चक्कर में कुछ तो वहाँ पहुंच रहे हैं, कुछ वर्चुअल है, तो मैंने आधा कर लिया, 1-2 दिन आधा दूंगा, 2 दिन ये दवाई देनी नहीं सब वजन इसका 9,600 है, ज्यादा कम नहीं है, ठीक है, 2.5 ml सुबह शाम, 4 ml सुबह शाम, 2.5 ml 3 सब लिखा हुआ है, ठीक है, नेबुलाइजर में रेस्क्यू डाल के दिन में 3 बार इसको नेबुलाइजर, 5 दिन की दवाई है, कोई तुम्हें शक लगे तो शाम को 2 मिनट के लिए ले आना, 6 बजे में फिर इसकी छाती सुन लूंगा, हाँ भाई कुछ दवाई की एक खुराक से क्या फायदा, ठीक है, क्योंकि कल परसों 3 बार, अभी तुम एक खुराक तीनों दवाई की दे देना, और एक नेबुलाइजर अब दे देना, 11 बजे 11:30 बजे, एक 4-5 बजे कर देना, फिर मुझे एक बार दिखा देना 6 बजे से, तसल्ली हो जाएगी तुम्हारी, 500 ठीक है, दवाई सही है जी, डिस्काउंट भी देता है जी, बिल भी देता है, मैं अपनी घर की भी लेता हूँ, देखो मैंने खरीदी है, ले लो रसीद चल जाओ, हरनूर नमस्कार जी। क्या हो गया हरनूर जी को?
इसका ना गला बहुत खराब है, आवाज भी चेंज हो गई।
बुखार तो नहीं हुआ?
बुखार हल्का गर्म लग रहा था, मैं तो सुबह से इसने मेरे को चेक नहीं करने दिया।
अब किसी हालत है रहती नहीं।
हाँ जी।
मुंह खोलो बेटा, आँख खोलो बेटा। गला खराब है,
बहुत
ठंडा वंडा खा ले क्या वजह से?
तो इसको मैंने संतरा
ये रुमाल तुम्हारा है?
नहीं।
शुक्र है छाती टच होती। बेटे इनका रुमाल गिर गया है जी का, पकड़ा दे बेटा।
बस गला ही पकड़ पकड़ के रो रहा है।
हाँ गला पकड़ के रो रहा है, ठीक हो जाएगा।
और ऐसे मुंह खोल लेता है, जीभ बाहर निकाल लेता है, और खांसी भी हो रही है।
ये लो
खांसी में सिर्फ पड़ा हुआ जाता है।
कौन सा वाला ना? पिछली बार वाला?
हाँ जी।
मैं देख लेता हूँ। एक सिरप ये 3.5 ml सुबह शाम, 4 ml 3 बार, 4 ml 5 दिन अच्छे से लेना। खांसी गला ठीक हो जाएगा। फीवर आया तो 2 लोग दे देना। 1 सेकंड। अब तुम कह रहे हो पिछली बार का सिरप तुम्हारे पास पड़ा है, वो ऑरेंज वाला। सेकंड नंबर वाले की जगह वो ऑरेंज वाला यूज कर लेना, ठीक है जी? ये तुम्हारा काम आ गया। सेम डोज, और ये और ये लेनी पड़ेगी, दोनों भी पड़ी होगी। दवाई चालू कर दो, ठीक हो जाएगी।
बिल्कुल थोड़ा थोड़ा, वरना पहले ठीक करता था। अब ये नहीं ठीक करता।
2 ml सुबह शाम, 2.5 ml एक बार। आपके लिए बोले 2.5 ml 3 बार। आप नेबुलाइजर में बीडी कॉट डाल देना, क्योंकि ये बोल यहाँ देती ना, बीडी कॉट यहाँ डाल देना। सुबह और शाम एक एक रेस्पिरेशन से नेबुलाइज कर देना। हो सके तो कमरे में थोड़ी स्टीम इकट्ठी कर देना, स्टीम थोड़ी सी गोद, ठीक है ना। ये तो सुबह शाम देना, स्टीम आप कमरे में इकट्ठी कर देना, आपको जिसको रिलैक्स, ठीक है। ये एक हफ्ता भर कर देना, कोई दिक्कत तो नहीं।
सर एक चीज होगी, वो प्रैक्टिस के दांत आ रहे हैं, इसलिए प्रोटीन वो कर रहा, तो उसके लिए कुछ
नहीं करना।
अभी है वैसे इसके लिए
आ जाएगी, नॉर्मल चीज है। विटामिन डी की ड्रॉप्स देनी है, बीटा D3 और जाइटी जेल लगाते हैं मसूड़ों पे। मसूड़ों पे मालिश करने के लिए या तो जाइटी जेल यूज कर सकते हो, इसी पर्पज से होता है, या प्योर हनी हो तो उसकी मसाज करके वो दे दिया।
सर फोन पे कर सकती हूँ?
हाँ, फोन पे कर दो मेरे नंबर से, बाहर कोड लगा हुआ, उस पर जाके कर देना, भैया को दिखा दियो, कोई दिक्कत नहीं।
ये होगा सर। बाहर भी है क्या सर?
हाँ, बाहर भी लगा,
ये है ना?
इधर से चले जाओ भाई, बंद है।
हाँ, एक क्वेश्चन, जैसे बच्चे को लॉन्ग ड्राइव पे ले जाते हैं, 5 साल का बड़ा बच्चा, वो बट बहुत ज्यादा करता है, जाए नहीं पाते।
लॉन्ग ड्राइव को कुछ किस्तों में करा करो, 2-2 घंटे चला के फिर रोक लिया करो, कुछ दिक्कत नहीं।
अच्छा, वैसे कुछ नहीं होता, आराम से।
नहीं, और बच्चे को फ्रंट सीट पे बिठाओ, साथ वाली सीट पे सही रहेगा।
ठीक है।
आ जाओ आराम से। नमस्कार भाई।
Hello. The things is not audible to the virtual people who are attending the conference. So kindly unmute. We are able to see you, but we are not able to hear anything.
Did you not hear any of the talk? Did you hear us now? Virtual people?
Yes, now the voice is coming.
And the screen share is okay? The Zoom share is also okay. Can you hear us now?
I can hear you now. Thank you so much.
Okay. So basically, yeah, active cooling during the transport, the advantage is you're actively cooling and you've got a servo control machine for that. So therefore, as soon as you reach the unit, you put the jacket on, it takes about 15-20 minutes for it to reach the temperature. And after that, it is going to be maintained. So there's no question of variability of the temperature. Any other questions? Yeah, kindly put the vaccination certificate in the group. I've already messaged in the group. Yes, okay, thank you very much. And I think Dr. Ravi Swami's talk is going to post lunch. So in the meantime, can we get Dr. Deepak Vasudev, who's a consultant neonatologist pediatrician at Apollo State Hospital, and he's going to talk us through amplitude EEG in HIV and its additional clinical application. We also have amplitude EEG in the workshop. So thank you. How many of you are using amplitude? And any benefits virtual, anybody has seen anybody using amplitude EEG?
Yes, sir. We are just started using in KGMU.
Okay, thank you. Cool. If you're feeling, next step for handling and data point and do an exercise a long way. Hopefully we'll get some peace or refreshment and organizing things. That give you the stick. Here now. Last one you went, huh? What is that? Come down, HP is there. Just come down here.
Just take out and then sent you on WhatsApp also, right? Yeah. Yes. My complete laptop.
Cancel ಮಾಡಿ. ಕ್ಯಾನ್ಸಲ್ ಮಾಡಿದ್ದು.
ನನಗೆ ಇದು ಮಾಡಿದ್ರೆ ಬರಲ್ಲ, ಇಲ್ಲಿ ಶೇರಲ್ಲಿ
ಇದನ್ನ ಜಾಯಿನ್ ಮಾಡಿ.
ಈಗ
ಹೌದು. ರೈಟ್ ಶೇರ್ ಮಾಡಿದ್ದೀನಿ.
One light. So I send it from school to you.
Link on the WhatsApp maybe, but
This is WhatsApp. You can, but you need more. So I think yes, HP you can just see once more. Yeah. Is it okay if you take like yeah, you can, but okay. Or we want to do slide share, anybody's slide share. But you can happen. Open the next topic. Okay. I will send you. I email you. What to put? Simple Jack is complicated every time. Just WhatsApp group. Now you see. Yeah, ಈಗ ಒಂದು ಕಳ್ಸಿದೆ ನೋಡಿ ಅದಾಗ್ತಿದೆ ನಿಮ್ ವಾಟ್ಸ್ಆಪ್ ಓಪನ್ ಮಾಡಿ ಓಪನ್ ಮಾಡಿ You can hear me now, right? Or from here. You can see the screen, right? Yeah. So this is briefly about amplitude integrated EEG. So the aim of this talk, 20-minute talk, would be how it works. Okay, how we can use it in identification for cooling and seizure reduction, and also for prognosis. Yeah, and also time permits, we can think about other scenarios where this amplitude integrated EEG is used. Next slide, please. All right, so this has been extrapolated from adults, yeah, because first used in adults by Pryor and Maynard in the 60s, and this came into the NICU 2 decades later. The reason for this interest in
ಆಲ್ರೆಡಿ ಇದೆ
ಇವಾಗ ಡಿಸ್ಟರ್ಬೆನ್ಸ್
ಚೆನ್ನಾಗಿರ್ಬೇಕು ಆಮೇಲೆ ಮಟನ್ ಕೇಳ್ಬೇಕು
ಡಿಸ್ಟರ್ಬ್ ಇಲ್ಲಿ ಇಟ್ಕೊಳ್ಳೋದು
ಕೀಬೋರ್ಡ್ ಓಪನ್ ಮಾಡಿದ್ರೆ ಸಾಕು.
ಕೀಬೋರ್ಡ್ ಎಲ್ಲಿ ಓಪನ್
ಅವ್ನು ಓಪನ್ ಮಾಡ್ಬಿಟ್ಟು ಅದು ಸೇಲ್ ಕೊಟ್ಟರೆ ಕ್ಯಾಮ್ರಾದಲ್ಲಿ ತಾನೇ ವಿಚಾರ ಮಾಡೋದು. ಈಗ ಯಾರಾದ್ರೂ ಇದ್ದೀವಿ ಒಂದು ಎರಡು ಟಾಪಿಕ್ ಇತ್ತು.
ನೆಕ್ಸ್ಟ್
ಆಯ್ತಾ
ನೋಡಿ ಸರ್ ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್.
Good afternoon, everybody. Hi, good afternoon, everybody. Can you all just sit down? Thank you very much for coming back to this postgraduate session. I know we all high with the sugars. So this session, we will have 3 talks very quickly, and then we'll move on to the panel discussion. Or we'll have 3 talks, then we'll go on to the workshop station. Finally, we end up with the panel discussion. We will cover up and then we'll finish on time. There's no need to worry about it. So Dr. Suresh is here to talk us through about blood and brain biomarkers in the cell. Thanks a lot. Good afternoon, everybody. You all had a brief session about cooling. So most of the time in this particular talk, I'm actually talking with regard to blood and brain biomarkers. So as we all know that therapeutic hypothermia is one of the roadmarks of the cancer in history of brain. So the past 15 years, since 2010, including a few interviews with the control diaphragm, it's been proved that cooling has helped in the reduction of disability and mortality. So today I'll just be talking with regard to the blood and brain biomarkers. So whenever we get a child and we need to start counseling to the patient's parents with regard to the cooling, it's the clinician's dilemma. It's a tough decision in how you have to explain to the parents with regard to what prognostic features you take into consideration and what are the prognostic features different in the pre-cooling area and the current cooling area as well. And most of the times the clinician's dilemma is met when the parents ask the question, is the child right? And what are the figures in status? It is a very difficult situation, but we have to take all these prognostic factors into consideration. So the clinical examination of the patient, along with the amplitude EEG, the neurophysical study, and the imaging, the ultrasound, MRI, and the serum biomarkers. It is not just only a single prognostic factor. Obviously, taking the clinical pictures into consideration, along with these all aligned, it will help in the prognostic features. So what are these biomarkers? So biomarkers, these are molecules which are released to a specific organ impulses, especially with the acute injury to that particular organ in terms in terms of hypoxic encephalopathy. But where are these biomarkers obtained from? The present in blood, the present in serum, the present in saliva, and the present in CSF blood. So what are the primary goal of these biomarkers? So these biomarkers, this will establish with regard to the clinical condition of the patient. They will help in the prognostic factors. For example, once a child is in the criteria is fulfilled with regard to cooling, you can screen the patient, then following the screening, monitoring of the patient. After the monitoring, then this will help in the diagnostic features as well. So, what are these biomarkers? Now, again, there's a large scale validation is needed in terms of many trials as well. You have some of these biomarkers which are not organ specific, but they are like the inflammatory cytokines, they're not particularly organ specific, but there are other biomarkers which are organ specific. For example, this is a summary of biomarker characteristics. The one, the PDNF, it's the brain-derived neurofactor. So this is usually secreted by the neural progenitor stem cells. Again, these are released after brain injury, neuronal astrocyte cell death, and the S100B. This is a protein that binds calcium as well, and is a major component of the cytosol in various cell types. Again, this is released predominantly in the astrocyte death, and it is released from other tissue damage as well. Then you have the gamma fibrillary acidic protein. Again, this is a specific marker of differentiated astrocyte released after astrocyte death. So these biomarkers are mainly released, especially with the cell death as well. Then you have the neuron specific endolase as well. So again, this is released after the neuronal death. Now, what are the potential use in the neonatal brain injury? If you see these biomarkers, the S100B, including 6, the gamma fibrillary acidic protein, and the neuron specific endolase. Now, they're located either in cord blood, CSF blood, and CSF as well. And what is the usefulness with regard to neonatal ischemic encephalopathy? You have the S100B, again, this is associated with growth restriction of trisomy 21. The 1+ indicates mild usefulness, the 2+ indicates moderate, and the 3 pluses indicate the good prognostic factors with regard to HIV. Here we have the neuron-specific endolase with the use, which has been very useful for neonates with HIV. So identifying early diagnostic markers associated with neonatal hypoxia, encephalopathy. So because we have very serum-specific biomarkers, but what biomarkers are very essential for HIV diagnosis? So in this particular study, so the patients suspected of neonatal HIV, this was a study done from 2015 to 2020. The criteria was one of the following, like classical abruption, cord collapse of fetal distress with an ABGA score of less than 5 to 10 minutes of life, and need for ventilation beyond 10 minutes of life, and acidosis where the pH was less than 7.2 or a base deficit of more than -10. This was taken into consideration, and numbers were totally around 80, and they had excluded babies with congenital anomalies as well, and premature babies in this particular study. So 6 hours before blood biomarkers before 6 hours after birth was taken into consideration. Then you had 67 neonatal babies. Again, they were staged into grade 1 HI and grade 2 HI as well. So in this staging, the stage 1 without hypothermia injury, they were not cooled, whereas the stage 2 hypothermia rescue therapy was initiated at 72 hours and MRI at 2 weeks of life. So in this particular the study, the demographic statistics, there were around 67 newborns. And if you see in this particular demographic studies, outborn babies were more in stage 2 and 3 in comparison to the child stage 1. So what are the differences in blood biomarkers, especially for between group 1 and group 2? The group 2 included moderate and severe HIV, and the group 1 was mild HIV. So if you take both the groups, the WBCs, the creatinine, lactate, these varied between the group 1 and the group 2, but the platelets, hemoglobin, the liver function test, the creatinine, prothrombin time, and albumin glucose, and the electrolytes and CKMB, there is not much alteration between the group 1 and group 2. Now the differences in blood biomarkers correlating with MRI results. Again, these the group 2 which are moderate to severe, again they were graded to group 3 with mild MRI changes, and group 4 with moderate to severe MRI changes as well. This was around in 42 patients with neonatal HIV. This was after the hypothermia rescue therapy. Of all this, they found that lactate, prothrombin time, and albumin. This tends to vary between the group 3 and the group 4. Because the group 3 once had mild MRI changes, whereas the group 4 had moderate to severe MRI changes. So, do you apply one single biomarker or do you take a combination of biomarkers? That is what this determines. They are taken single one like lactate if it's more than 45 milligrams per deciliter and white cell count of more than 27 or a creatinine of more than 0.9 for LDH more than 1000. But in combination as well, they are taken. For example, lactate more than 45 plus LDH as well. If you see the positive predictive value was quite high in the combination group with the lactate more than 45 LDH and the negative predictive value of 50. And usually with just only the lactate, the positive predictive value was 82.6 and the negative predictive value was 71. So again, how this was classified as bucket. So these blood biomarkers were taken, first clinical examination was done, and based on the clinical signs, for example, with the baby cry after stimulation or intact facial expression, either if there was absence of 1 or 2 and if the lactate is more than 45 milligrams per deciliter, they started the hypothermia therapy, or if the lactate was less than 45, this was closely and carefully monitored as well. So if you had both maybe 1 and 2 were positive and the lactate and LDH were taken into consideration as well. And especially the lactate was more than 45 and LDH was more than 1000 and hypothermia, the rescue therapy was started. If the lactate was more than 45 and LDH less than 1000, then with strong history of HI, the cooling was started. Without strong history of HI, this baby should carefully monitored. So what are the serum biomarkers? Again, prior to the cooling era and post-cooling era, prior to the cooling era, they suggested that lactate levels within the first hour of the birth was associated with degree of encephalopathy. Now the post-cooling area, they don't consider only the lactate value. They suggest lactate value of more than 4.4 millimole per liter, highly predictive, with combination with raised LDL, CK, and uric acid levels. Lactate level alone is a very poor predictor of good outcome. So the LDL again, more than 2,500 at 24 hours predicted. This was during the pre-cooling area. But in the post-cooling area, it was more than 3,500 at 22 hours. So the conclusions, again, biomarkers, which will help to determine the time when the injury occurs. This is very important because the injury often begins in vitro and too much time has elapsed from the brain injury. The neonate is not benefit from treatment with hypothermia. And the timing is very important with regard to medical legal implications, both for the obstetric and neonatal team taking care of the patient. Again, the lactate, creatinine, LDH, and WBC count may be helpful for identifying an appropriate time. And the lactate level in the first 6 after birth can indicate the severity. Again, with the MRI changes and prothrombin usage, timing the indicated lesions indicating the severity of HIE. However, as I said, there are non-organ specific serum biomarkers. There should be a validated physical use of these biomarkers for HIE as well. Still, the research, there is not a strict criteria that these are the blood tests which we need to monitor, but there's a little bit of vast research still awaited. Thank you. Any questions? No other questions. Thank you so much. This was not a very easy topic. And may I invite Mr. Chakti, who is the professor in PhD Medical College. And he's going to talk us through the medical aspect of therapy. As I said, I mentioned very briefly one of our known questions of 1.5 CR. Now we have the field trial where they gave a statement that shooting itself is a malpractice in India. And then we have a position statement where from the NNF they are giving us good guidelines on who to cool and where to cool, which are the right centers to be cooling these babies in. And there are a lot of other medical legal issues which I think Sidhu is going to do some interactive sessions and wake us all up. Am I audible? Okay, it will not be a single or monotonous talk. It will be interactive definitely. How many of your courses? Okay. How many of your consultants? How many of your food? How many of you food? I think you guys with servo control, if I'm not wrong. Yeah. And you? The same. Very good. Fine. So what about this? So it was in July. This is working group. Yeah, it was in July 28th. We got a message or a publication in Indian Pediatrics. I've circulated it in the group. You can read it. No ifs and buts. Schooling is harmful in low middle income countries. India is one of the countries which is considered lower middle income country. Subsequently, my first message went to Pratap and a few of our other friends who were part of the elites and who were actively polling. What next? So onwards we have a lot of discussion because if you see through last few workshops we have been doing as a team. This topic was never part of the workshop. This is the first time this topic has been included in a schooling workshop. We do conduct something called a NCAT. Pratap was the coordinator for that. We call it as Neuro Cooling and Transport workshop. We have conducted it across the state. So subsequently, we thought we'll come up with this topic to understand the medical legal aspects of that. So if you guys have read about it, or most of you who know, after that, what are the thought process? Did you decide to school and start with you? You wanted to continue with schooling? I'll not take more than 15 minutes. Okay. What is what nonsense? Okay, when there's a literature saying that it is harmful if somebody comes up with a litigation. Yes. I don't think so. It says that it's public or private sector. Yeah, but it applies to everyone for that. Everyone. It's a generalized study. Your thought process on that?
I think that was the first and after that subsequently actually we have a series of
thought process, not about the article.
Yeah, so so what we are continuing right now we have the outbound load
Maybe as some supplies we are going to put on.
Yeah, so right now we are continuing. Right now we are.
Is there anyone who doesn't want to pull in the current instead of listening to all the toxins?
Definitely, talks have been going on. What we should do, still there has been no way.
Now I will think what I do. Can you use the mic, sir, please? That is only one stage. I think this talk should clear most of your confusion. That is what I wanted to start with it as, not to create more confusion. As rightly said, there was a helix trial published. The publication was but there's a review paper which came in Indian Pediatrics which published in July 2023. Okay, let us not go deep into that. But subsequently, NNF with all the servers who are doing coding in our country came up with the position statement. That what is the recommendation? That is what we are going to discuss in the subsequent class. Okay, and that covers the medical legal aspect for me. If anything is there, I'm happy to discuss. Okay, as we all know, therapeutic hypothermia is now offered as a standard of care for the treatment of newborns with moderate to severe HIV in high income countries. Whereas in low income countries, including India, based on the results of studies in high income countries, therapeutic hypothermia has been offered as a treatment option. It is not as established kind of care in our country as of now, till the position statement. Okay. Using a variety of cooling methods, even though there has been uncertainty with respect to its efficacy and safety in our countries. Subsequently, hypothermia for moderate to severe immunity encephalopathy in low middle income countries is the trial name. A lot of people ask me what is this helix study? It is nothing but hypothermia was done for moderate to severe immunity encephalopathy babies in middle income countries. What they found out was they enrolled 408 neonates. In that, the primary outcome says there is no effect on the primary outcome of death or of moderate or severe disability at 18 to 24 months. Whereas the only difference was in the secondary outcome, which showed that the risk of death before discharge was significantly increased in the hypothermia. This is what I've taken from the helix. So the primary outcome said it is beneficial, but the risk of death increased in the hypothermia group only in the secondary outcome. Coming to the other trials, do you think there were no trials prior to this? There have been 16 randomized controlled trials prior to this, all from the lower and middle income countries. 9 of them are from India. But what happened was none individually reported either a significant reduction or increase in neonatal mortality. They are not reported it earlier. Whereas the debate on the usage of therapeutic hypothermia as a treatment modality with moderate to severe HIE started once the helix publication came into picture. Till then, it was a treatment option for us. A balanced reappraisal of this treatment modality in the Indian context was decided in August, and subsequently in October, the position statement came. What is the evidence? The NNF, National Neurological Forum India, went through this kind of literature through the PubMed research. Okay, what they looked for, what was the death before discharge in neonates who were ill or not ill, and what was the cord pH at admission. That they were very particular about. It has to be within 1 hour of life. As Madam rightly get outborn units within 1 hour. That is the difficulty. And they wanted to understand what was there a difference between inborn units and outborn units. And what was the temperature at admission. Mind you, when we do start with passive cooling, as Dr. Deepa rightly said, we start during the retrieval phase itself. The temperature at admission has got a significant effect on the baby. Because earlier some people used to tell them don't put on the warmer, give the baby like that, you come. And the baby comes to 32 degrees Celsius, the impact is quite bad. And death or severe disability and cerebral palsy outcome. These were the evidences they looked for in the published data. Subsequently, they came up with the position statement in October 2021, that is 2 months back. What they told us, what is the recommendation currently as per NNF India is, therapeutic hypothermia is likely to decrease death or severe disability and cerebral palsy at 18 to 24 months, even in lower middle income countries compared to higher income countries. So NNF India agrees that it reduces the death and disability in moderate to severe encephalopathy. Let us be very clear on that. There is a significant heterogeneity in the studies from LMICs compared to higher income countries, which reported mortality prior to discharge. The helix, what they are speaking about is. In neonates with hypothermia at admission and unclear evidence of severe intrapartum asphyxia, in the sense of cord pH more than 7 or less than 7, was not available in most of the studies or literature. So there was uncertainty of the benefit for the babies coming outborn or late. So there is a benefit of more harm than good in considering outborn. Okay. As the risk of death increases with the severe encephalopathy, need for invasive ventilation and inotropic support, availability of optimum neonatal intensive care facilities should be there in order to offer therapeutic hypothermia as a treatment modality. The possible effects of ethnicity, biologic factors, differences in inter exposures on the outcomes of neonates with moderate to severe encephalopathy would need further investigation. This is the area of interest or research if somebody wants to do. It's to consider into that. Subsequently, there is something called as International License Committee on Resuscitation and the American Heart Association 2020 guidelines. They have defined a protocol, whom to cool, when to cool, where to cool. Okay. So, where should therapeutic hypothermia be offered? Do you think every center can afford that? So, there is a definition from the NNF India. Strongly recommend that health facilities may have high quality neonatal intensive care facilities and practices in existence prior to starting therapeutic hypothermia. What do they understand by high quality neonatal intensive care facilities? Level 3 and level 4 units only. There is certain accreditation process in NNF India, as we all understand. Based on that, they say that level 3 units and above have to start therapeutic hypothermia. And along with that, they should have a bedside access to USG computed tomography, magnetic resonance imaging, and EEG. And they should have facilities to have neonatologists both on call and on site 24/7. This is possible. The most difficult part is this. They have to have nurses trained in neuro to advanced care. Desirable nurse patient ratio is 1:1 or 1:2. So now the next question to you guys is, who are schooling now? What is your nurse patient ratio? If you would like to share. I can share them. What's yeah. But of same 1:1. I think. Is it practically feasible? Public sectors, we will put it in better. Public sectors, yeah. So that is where the difference comes in. That is where the elite trial had variations in that. But when these, why are these people confident of promoting therapeutic hypothermia? I think that should be the take-home message for you. They don't without any hindrance or counter that we do fully. Because they have a backup where they say that every 1:1 care, including the neonatologist on call or on site 24/7. Okay. Yeah. Which neonates? I think this part has been discussed. This is quite clear. More than 36 weeks of gestation, more than 1.8 kilos. It should be less than 6 hours of life. Admission temperature preferably somewhere around 36 to 37.4. If you have not started schooling, mind you that. Okay. And pH less than 7 and base excess more than 60. And Apgar score and history of acute perinatal event in the sense observed through the or anything of that sort. And there should be evidence of moderate to severe encephalopathy. If there is a chance of child going from moderate to mild encephalopathy, you live for 1 hour and then try to decide whether to feel or not. That is the eminence position statement right now. Okay, which unit should not be cooled? That is crystal clear. Moribund units, units with major prenatal or genetic abnormalities, units with severe IUGR, evidence of severe coagulopathy, severe heteroma or intracranial hemorrhage, evidence of insufficient evidence of benefit of hypothermia offered beyond 6 hours. There are certain centers who are trying beyond 6 hours, 8 hours or something. So they said not to do after that. Which method to be used for cooling? As most of the centers are agreeing on servo control, so it is servo control cooling standardized. But they also say that if you don't have a servo control device such as Delphax or PCM device, if you want to use that, make sure your nursing ratio is 1:1, so that if there is a shoot up in the temperature, you have to take corrective steps immediately. That is the thought process. What is the future course? How should we go about? Do you think if somebody, mind is that it should not happen. Some educated person comes here, full day will be at day 3, there is no significant improvement, you have got EEG with you in hand, it shows severe flat pattern instead of 3 days of effective cooling. He gets this article from somewhere, the cooling is harmful. He comes back and asks you, what would be your situation? And it's the 10% would be all of it. Mind you, it should not happen. Yeah, I mean, this is some cases, some phase 3 completely flat and they don't get to EEG will be showing the flat line. EEG flat line. It's more of counseling the parents, counseling the father is most important thing. I think that it is only one of the therapeutic intervention and definitely next prognostication wise you have to just see follow up. It's prognostication, I mean counseling the parents and telling prognostication so you can understand the effects. Because there is going to be advantage, it will be advantage. But it is not a disadvantage.
Absolutely right. I think this is never a retrospective thing. At 3 days, you should not be struggling to say what will happen now if the father goes and sees the hospital or the clinician. It should be the 3rd day. You should be the best friend of the father. I mean, what I mean to say is you should be so good with the family. You're supportive. You're empathetic towards them. This is the only way it is going to work. And more importantly, you should have a clear-cut documentation of your communication as well as your decision to cool. In those cases where the criteria doesn't fit, or there are a lot of, we have a session on that cool or not to cool. In those cases, also you should document why you did not offer cooling. Forget about now. This the lawsuit applies until the child is 18 years of age. Until then, they can visit us. They can come back anytime. They can come back anytime up to 18 years of age.
Therefore, you would never have remembered, even 6 months later also you cannot remember the exact detail. Whatever you don't write, it is not taken in the court of law. You must say, I've told so many people and all that, they are now creating a note and see, it doesn't matter. If you have written, only that is evidence. If you have not written, it's not evidence. So no retrospective things. It is the informed written consent. If you don't do that, they are liable for prosecution in any other procedure implied in any case. For that, you have to give them an informed consent. Because of it, you have to add anything exceptional. Maybe when you start to cool, right, you should document the cool. Again, when developed countries also to cool. Very significant of margin mortality. Yeah. If you ask me the question in contextual analysis to contract with the system, probably should not be in that position. That's my takeaway. But you can, you can say that why you cool and then you have another position statement. If you have 48 and so that is the reason why I said there is some future course planned by NSO. Centers who want to continue schooling, my request to you guys is to follow this. Okay, this has been discussed by few of my colleagues, Dr. Deepa highlighted on this, Dr. Mangal said, even Pratap also said. It is strongly urged that there is a need for individual patient data meta-analysis of trials from lower middle income countries to address some of the specific issues placed in the evidence generation currently from the IDEX. Okay, it is strongly recommended that there should be a national register of all the units with moderate to severe HIV who are being treated with therapeutic hypothermia without dialysis. Okay, to document information of both acute treatment and long-term developmental outcomes if possible up to 2 years of age. Such data should be used for monitoring practice, providing feedback to community units, offering therapeutic hypothermia to frame future policies that would safeguard units from harm from the intervention purpose. So I would request Pratap to start this analysis and if possible. Because the reason being, if somebody comes back with simple document of that, that document has been retrieved from the research section, the Google will not find it. Okay, but if somebody comes with that, we definitely don't have an answer to it. If it gets in some very stand, we don't have. But written informed consent is there, and hypothermia is still a treatment modality option. That is the take-home message. Provided you take a pre-consent, pre-written informed consent. Okay, thank you. Open to any questions. I have one now. What's your opinion of this position statement of NMA? If you get a outborn baby, 4 to 5 hours life, and without coordinate and without history of any perinatal scientific, what's your opinion regarding the position? That's this scenario. Absolutely, it's one of the toughest ones because the position statement is very clearly you have to be very safe. Number one. Number two, they are suggesting that all the criteria should be met, which is very difficult to do. What would I do? Basically, we have a very great relationship with a lot of different districts where we get the referrals from. That is what I do. I go there, I do training. Day in, day out, month on month, week on week, we do a lot of training. And then we are on the telephone with them all the time. Whenever they get a baby like this, immediately they will give us a call. This I'm talking about almost more than 100, 150 pediatric and neonatal practitioners across 3 states. Right? So at that point in time, we make a decision. Okay, this is right, this is what it is. Make it give the documentation. And then, if you fix the criteria, we will ask for a descriptive AFCAR. AFCAR is considered as one of the things, not just a blood test. Blood test is not available in say, for example, another school is one of the districts where we get highest number of babies. So people should, you have to derive that. In case of absence of other things, you have to derive that. In majority of moderate to severe, HIVs, it is obvious. And the baby would have told the teacher. Take-home message would be, if you are not able to get what this, see, only one criteria which is not taken here in that scenario is what this. And not just the part within 1 hour. At 1 hour. Oh, exactly. At 1 1 hour. Yeah. You're saying the previous comment. According to position statement, this should sentimental event should be there. Absolutely. And documented from the reference consultant. For that, it is not mandatory. Yeah. Correct, correct. If you don't have the avatar, it is very difficult. It is very difficult. Then you have to take a decision. And then stay in that. And you counsel the parents and the family when you are close to the cooling. You have started the cooling and the baby send to the organ. So according to the position statement, we were not in the safe period at that time. So we were. Don't go, I mean, one thing statement is not be workful. Yeah, it need not be your written in stone. It's not the following criteria. Absolutely. You, even if you take a level 3 energy, it is not a perfect energy. See, this is this case. Okay. This topic, the point to point thing, the exact word as this topic was put into this workshop to take off this difficulty. Yeah. Position statement is very clear. I spoke to Mangal, I spoke to Ravi. I think Ravi is going to talk in 2 minutes. Okay, they have told that these are the options. When we went back, I'll show you that. Okay, so first 3 criteria are must. Okay, if they fulfill all of the following criteria, among them you have to choose 3. It is a descriptive avatar, at least you can get as told by Dr. How do you get the descriptive? You get it from some particular center. Imagine I'm working in a medical college. I get from Srinivasari. I can't expect them to come with abstract role with me. But what we did was we went back to those citizens saying that kindly use an abstract. They started doing that. Yeah, exactly. There are 2 things here. Everyone should not do. That's the baseline statement. If you are trying to prove, you should have a well-equipped community intensive care unit as defined by NMF, along with trained personnel with facilities and expertise available for leadership and follow. They are not stopping at 72 hours of life. You have to take it till 2 years of life. The first follow-up or the baseline data, they are going to come up with 5 years data now. We don't have any of the centers what they are doing. I think Madam shared our data right now. It's an initial stage. Definitely they will be following up and coming up over a period of time. Okay, with the basic message was every level 1 or level 2 person will buy a medical machine. This is I've got cooling, I'll attract people to come. No. Because the first thing, typically you guys will have 1:1 people. That has been crystal clear. I've made these guys say because I know that they do 1:1 care. Even that is the only possibility they can convince the parents. And decisions may change. Okay, if you start doing that, if they come back and ask you, they have a written informed consent. So that is all your problem. Okay, the other one is, see, you know your references. Say it's coming from 50 kilometers area in and around, and you know there are prominent people. You have to go and have dialogue with them. You have to go and have CMEs done. You have to do the workshops with them. And secondly, why not develop a transport service? Why we are not talking about it? Not even one baby was retrieved in the Helix trial. In our place, all babies are retrieved. First, unit in the country who has got active cooling data, in the whole of India, basically. So if you do that, why do you think it's going to be hard? So there is a lot of hard work and the background work that you do. So that you can really be in the safe zone. Everywhere, majority of the sites, even in America, it's true. Even in European society, it's true. 90% of litigation happens because of poor communication. 90% documentation. And documentation. So kindly ensure that your trainees, everybody you are in training, don't use the shortcut. Never want to send it. Right? Do proper documentation. We have audio video counseling. That's stored in the past. It's stored forever. this is what we need to start doing rather than saying, how about only level, but I still want to do. I still should not be caught by the police. You cannot do that. So that way, because it's for majority of the babies deserving to be food will be done in a place where, you know, appropriate center. We have nitrate, so 8 babies in our cohort need a nitrate. Right? If we did not have nitrate, where would that baby be? In the car, or we will be something to send some letter. How would you send if you don't have your own transport service? Or if the other person is not receiving this baby, who's really ventilated, very sick baby, you know, 100% oxygen, how would you do that? So it all boils down to how well you make the entire process of your system count, along with your referral basis, should have absolute confidence in you to make you up, even if you are not in the night. And then asking for that, right? And therefore, you just have to send. We send our ambulances within 20 minutes of receiving the call. And majority of our retrievals are more than 200 kilometers. We're doing it. Don't do cooling. No, don't do. Government center, it's not recommended. Don't have easier in it. You have to go for a Essentials are going for a Karnataka state has already started that. The money payment. You can make the who's who there. 35,000. No, we have to give it to the superintendent. There are budgets for I have a local issue. Okay. I tell you one thing. I run a medical college. I have a level 3 affiliate medical college, private medical college. Okay. We will do sparkling or semination theory. See. We can get a critical machine of 18. What is your cost? Yeah, we are thinking about 35,000 for application. I think we are good out of it. Let us be clear on that. Because Karnataka is the only state in the country where we led the way in assessing all the SLCs of Karnataka. 40 of them. And assessed thoroughly by experts and given what are the deficiencies that you have got in front of the Ministry of Women and China. So things have started going. Things have started getting set up. A lot of people are very good in other units. We are not here to discourage people. But at the same time, they should not be poor until they are some confused and they don't have a. This statement, what you said, is absolutely right. Where you're worried about 35,000, you don't think about 15. Leave that. No, it's 2 years. It's 2 years. You are ready to buy. I think with this interest, we can get connected. So let that be for discussion for later. Okay. And thank you very much, Sidhu. You've just given us a very provocative, this thing, you know, thoughtful talk. Thank you very much, and thank everybody for you know being part of the discussion. And now I think what we'll do, Ravi Swami's talk, we will delay to the last because he's starting from that. So we can all gather together and then split for the workshop, right? And then once the workshop is finished, we can go to panel discussion and then finish the show. So here, how do we divide it? Unless people have videos of their So I think that's another thing we are doing it. I think because the group is very small anyway, so we will all gather together and one person demonstrates the machine. Then we will move on, all of us, to amplitude EEG. Then we'll move on to some other machines that people want to demonstrate. Okay. So the center stage will bring all the machines one after the other. Okay. Yeah. And each one of them, will take about 10-15 minutes. No, video can cover that. No? Right. So basically, over a lot of machines, you're very familiar with these things. You guys want to come in the front? I think it's probably better. Okay. Does anyone have a manifest? Yeah, can I call it manifest? Right, obviously you've got a baby here, then you need to cool this baby. So everybody has got this sort of machine, servo control? No. Yeah? No. So basically this is a very simple technology. There is this, this is not a reusable one. This is a disposable one. But a lot of people reuse it because of cost issues and all that. And it's not recommended to use after maybe 2 or 3. And you have to make sure that you have to clear it or impure it really well, because infection risk is also there. So if you carefully look at it, there are a lot of columns in between. So you can all later come and have a feel for it individually. So there's a column here basically, and you have this one. Like that. Move forward. This is one of the examples of servo control machine, and you also have other brands which are organized here. So basically, you put in distilled water in here, 1 liter, 3 liters of the distilled water here, and once you switch on, there is an inlet and there is an outlet here. These pipes, right? And then here also there is one inlet and there is one outlet. So once you start, the water starts getting inside this and goes through all the channels, right? And you have an option here to set the temperature. So these are all automatic. and then they will set the temperatures around 32.5 degrees centigrade. And it usually takes about 8, 9, 10 minutes, about 15 to 20 minutes to for the baby to start attaining the temperature, the required desired temperature. So here, there is also rectal core thermometer. This is the rectal thermometer, and this is the one which is close to the surface of the skin. We generally tend to put it here, just for the practical reason. And rectal thermometer to insert until about 4 centimeters. And this will basically collect both the data and then use the data to keep the water as cool as possible, or if the baby is going very hypothermic, it will be calm. Right? So that is as basic as it gets. So once you set it up, there is a display of number of hours of usage also on majority of these servo control, and then it will keep telling you the nurses will monitor this every hour. So if you go on to the Toby website, the NPU, you get all these monitoring forms. Don't reinvent the wheel. So go there, get all the forms. The ones that showed about the Toby chart. The conference chart which is available there. The documentation for the temperature hourly is available there. So make a file for each day. Right? At least there it is helpful for you to collect the data as well. Otherwise, if you write in the notes, it's not possible. Okay? And then the rest of documenting these things, every day, one conference code documentation should be there. That will also tell you whether the baby is improving or not. And once this is switched on, the machine does the whole job. So it just encircles around the baby. In my experience, you don't have to completely do the head like this. You can just leave it there, and that should be okay. And majority of the time, you put the lines in the chicken. So those lines, and again, make sure that you ensure that it's coming out nicely, and you are seeing those lines there. That is also important. Don't just cover everything. These are quite powerful. Even if you can, contact like this also, it will keep the temperature nice. And wrapping up the legs and all that. But again, anytime you do, you have to keep changing the position of the baby, and then the skin care is important. Again, Ram showed us how the feeding and snacking process can happen very early if that happens. And that is also a reflection of the care that we have. And anywhere, don't do anything which is making it very constricted. Okay, it should just be used there. It should just go around it and use there. Apart from that, I don't think there is anything major in this. After 72 hours, basically you start the rewarming phase, whether it is 0.2 degree or 0.5 degree per hour, depending on the condition of the baby. If you start with 0.5, if there is further seizures or anything that you were discussing, you go down very slowly to reward. And that is all about this question. What we need to do. Okay. Any doubt on this? The Hypothermia was another one. I think there was some other indigenous Indian-based machines as well. So they will also come in the demonstrate that. Any doubt in the use of this? The practical points are: don't only do this and upstream your, the umbilical line. If there is a bleeding bad disease, you might just keep bleeding there. You will not notice it. The other thing is the rectal flow. Don't just insert too high or very low. Then whenever the nurses are bleeding, especially after the baby is part 2, then it is their duty to insert the family. So these are the things you have to practically apart from that, I don't think this is why it is so easy to do compared to the testing. So once the cooling is over, then obviously you just have to let that water drain. Servicing, empty the tank. They have a connected for the 20%. So these are the 3 come up and gather with you. So we also in our unit,
ಹೆಚ್ಚಿಗೆ ಮಾಡ್ತಾ ಕ್ಯಾಮ್ರಾಯಿಂದ ಔಟ್ ಕೊಡ್ಬೇಕು, ಕ್ಯಾಮ್ರಾಯಿಂದ ಔಟ್ ಕೊಡ್ಬೇಕು. ನಾವು ಬೆಳಿಗ್ಗೆಯಿಂದ ಆಗಿದೆ ನಾವು ಕ್ಯಾಮ್ರಾ ಹೆಚ್ಚಿಗೆ
Finish it up. No, after that we will go to we'll talk something about waste change. How you have that in while where you are having a performance with the here. And then you have a consumption map. For the spreadsheet and then what we do call as investment. You have then done assessment. Is the bill not coming down? Someone tell me 42 rupees. Kind of the that situation not helping you. Then you can start Here they haven't given the thermometer. They will, you have to have the actual thermometer, and only certain monitors will have the option for you to connect it. We have the Philips monitor. Regular monitors don't have actual flows. So in which case it becomes very difficult to do. It's up to the situation. If it is not ready, then obviously you cannot start. Make sure the food is not bad. Let's now move on to once this is done, I think we can take 5 to 10 minutes break. Then after that, we will start the panel discussion. And that will then be done. Video.
Once mastered, this technique can be done in 3 minutes comfortably. During the recording, it's important to check for influence and participation. Afterwards, in this video, you should have a good understanding of how to apply music and to make sure you receive good quality.
So, as I said, I took off those 4 channels. Okay, you want to show them how to What here? CPU and CPU and CPU and CPU, right? That I think people is regulate up. So here you have to pick up. Let's go. And one more thing is the reference. Generally, in the back, neutral. Generally, the supply one will be on the back. So that can neutral. And the machine will listen to you. That can write to you. In this view, that is the pattern. The pattern is what you see the lower line across the upper line. Here I'm saying you have a and also incidence. Incidence, like if it's more than 10 minutes, you will do the as stopping. want to correct the mistake. For A easy, we to at least 30 function. Few practical things would be like suppose that we have There's no coffee. Have you still logged in? No one is there. No one is there.
ನಾನು ತಿಳ್ಕೊಂಡಿದ್ದೆ ಮೆಚ್ಚಿ ಕಲ್ಕೊಡ್ತಾನೆ.
Hello. Is there any question from the virtual panel? Is anyone out there?
Pratap, I'm there.
Ravi, hi Ravi.
Hi.
Good. Virtually. Hi Ravi sir. Last time ಒಬ್ಬರಿಗೆ ಮಾತಾಡಿದ್ರೆ ಈಗ ಇದ್ರೆ one mark. Now try this. Yes, she said, please come back. Nobody told us that devices. We'll have coffee come. Now, Ravi sir, we'll get back with coffee sir. $1,000, sir. $1,000. नहीं, my dresses are clean white. I'm not wearing green, yellow, and all that stuff. Pink, green, yellow. Sir, this is funny. Yeah, figure like you would funny. Yeah, funny, sir. Yeah, funny. That's cool.
near deer park. Deer park. That area with the snakes kind of behind. The deer park is open area.
Yeah, please. But not hospitals. ಮಜಾ ಬರುತ್ತೆ ಏನು ಓದಕ್ಕಿಲ್ವಲ್ಲ ಅಂತ ನಾನು ಅಷ್ಟೇ ಹೇಳಿದ್ದು ಆ ಕ್ವಶನ್ ಓದೋ ಅಂತ ಹೇಳೋಣ ಎಂಜಾಯ್ ದಿಸ್ next presentation ready I have all this and he has taken the phone number. This program ಆಗಲ್ಲ ಅವೆಲ್ಲ ಕಾಪಿರೈಟ್ ನಮ್ದು ಮಾಡ್ಬೇಡ ನಾವು ಎಫರ್ಟ್ ಹಾಕಿ ಮಾಡ್ಬಿಡ್ತೀವಿ ग्रुप में क्यों है नॉलेज शेयर करने के लिए नॉट ये ऐसा नाम से देखो मुझे क्या पता है and you know the final law Hey, let's go in, man. Once you my job is madam.
ಅವ್ರು ಜಾಯಿನ್ ಮಾಡಕ್ ಟ್ರೈ ಮಾಡ್ತಿದಾರಂತೆ. ಅಕ್ಸೆಪ್ಟ್ ಯಾರು ಬಿಡ್ತಿಲ್ಲ ಅಂತ ಒಳಗಡೆ ಏನ್ ಮಾಡ್ಬೇಕು ಗೊತ್ತಿಲ್ಲ ಅಂದ್ರೆ ಹಿಂಗೆ ಬೇರೆ ಯಾರು ಕರೀಲಿ.
ಅವರು ಅವ್ರಿಗೆ ಲಾಗಿನ್ ಐಡಿ ಕೊಟ್ಬಿಟ್ಟು
Please join with the same link, sir.
ಇನ್ನೊಬ್ರು ಜಾಯಿನ್ ಆದ್ರೆ ಇವಾಗ
Actually, people are getting added and said we don't have anything to do with letting you in.
ಸರ್ ಇದು
Just add, sir.
ಸರ್ ಇದು ಇವಾಗ ಅವ್ರ ಬೇರೆ ಕ್ಲೈಂಟ್ ಜಾಯಿನ್ ಆಗ್ಬೇಕಂದ್ರೆ ಲಿಂಕ್ ನಾವೇನಾದ್ರು ಮಾಡ್ಕೊಂಡು ಅವರೇ ಡೈರೆಕ್ಟ್ ಜಾಯಿನ್ ಆಗ್ಬೇಕು. ಎಲ್ಲಿ ಹೇಳಿ? ಹಾ ಹಾ ಅದೇ ನಾವು ಕಾಪಿ ಪೇಸ್ಟ್ ಮಾಡ್ತೀವಲ್ಲ ಆ ನಂಬರ್.
Just find out whether they're coming on. Otherwise, you can just quickly. Gaurav, are you there?
Yes, sir. Yes, I am there.
ಅವ್ರ ನಂಬರ್ ಬೇಕು
ಅವ್ರಿಗೆ ಈ ಲಿಂಕ್ ಮತ್ತೆ ನಂಬರ್ ಬಗ್ಗೆ ಅದೇನ
ಹೌದಾ? ಈ ಭೂಮಿ
ನೀವು ಬನ್ನಿ ಅವ್ರು ಕೊಡಿ ಮೇಡಮ್ ಅವ್ರ ಫೋಟೋ ಹೊಡೆಯಕ್ಕೆ ಬರ್ತದೆ.
ಅದೇ ಕಳ್ಸಿದ್ರು. ಓಕೆ, ನಾನು ಫಾರ್ವರ್ಡ್ ಮಾಡಿ ಲಿಂಕ್.
ಈ ನಂಬರ್.
Yes, sir. I'm telling you the one.
Okay. In the meantime, thank you guys for here. And you guys can also participate in the management. So
So just wanted to, the slides are up. Just wanted to understand from you guys if you have any specific questions. Anything burning questions, anything.
Yes, President. Come on. Hey. Yeah, the more PGCM. Okay, ma'am, I'll tell you.
Only a pattern that is not more than. You can ask those people to. Okay. I can forward. There are some references to it. The hypothermia broad discussion was there, but regarding that there are no. Hello, thanks for the program. Share my presentation to all of them. You guys are in the group? Yeah. Okay. Fine. So I think, this is not the best way of doing it. I guess what we can do is, shall we just talk about the controversies surrounding the decision that we discussed today? And in that, I would want to ask Ram, if you get a referral of a patient who's about 4 hours of age, the reason for the referral is because baby did not cry, but was okay and started throwing fits. 4 hours of cry. And they termed this as moderate encephalopathy. Baby was a bit irritable before that. No other problems was noticed. There was mild abnormality in the CPG, and the baby had little perinatal depression. It did not cry for a little bit, and then after 1 minute of stimulation and a bit of bagging, it started crying. Right? So this is the scenario. What would you advise that referral center? Child is at the referral center. It's 4 hours of age. And the main purpose yeah, so CPG was abnormal. She took for section, and then baby didn't cry immediately. 1 minute of resuscitation, and not requiring drugs or anything. Then the baby started crying. Shifted to the ICU, and then when they monitored, it was very irritable. Around 4 hours, had a seizure. Yes, absolutely. Either they can send the baby in the transport. 4 hours. Yeah, 4 hours. 4 hours of baby. Because by the time we reach there and we visit the child, maybe more than but because your center is running active for the destination on the and go bring the child. And most of the centers, baby will be referred here. Okay. So whether baby can come along with the doctor or the referral center, and then you can start here the field. So you're saying we need to start cooling on this baby. And are there any other important parameters for the seizures that you would like to consider? Let's look at what you are okay. Yeah. Also the history of infection. Yeah. Yeah. There's the blood gas, if they had done it in the first 1 hour, they don't have the blood gas. So the solid state of affairs. No blood gas. So I would also take blood test culture, antibiotics can be shortly they can observe second so regarding severe like those of hypoglycemia example, hypoglycemia will be
So at that time, our team has reached. No, they can't. They don't have. So the team has reached there. You sent the team to retrieve the baby. The team has reached there. Then they took the history, and there are 2 babies who died in the past. That's the first time all the doctors don't know that 2 babies have died in the past, and they won't. Would that change? Yeah, it would definitely change my management. I would take more patients, whatever teaching metabolic. Some of them they can say that mostly and that's in the back of the screen. I would definitely take that for I don't think it matter. Why I'm asking this? We're going to extrapolate this. Sharma, can you describe? So this baby comes to your unit, and then obviously you have all the facilities. You have the cranial ultrasound scan, and then it showed abnormalities in there. It was not very specific. You know what case I'm doing. It was not very specific. Therefore, what is your next course of action? But I said, your unit is a good unit. You put the head probe on there, and then you found that the brain is abnormal. You still feel this way. Okay. So the take-home message is seizure itself can come under moderate and severe. You're kind of obliged to do. But then here what has happened, the scenario has changed. You see brain abnormality structurally on the ultrasound scan. So there is a past history of death in the family. Therefore, this could be a neurometabolic condition. So in this case, you don't have to kill. Or if you've already started cooling, you may have to stop it. So there is no hard and fast rule that you have to just keep doing only one way. And why things also Rampas have suggested one thing. It was mild, it became moderate. That is also true. If this baby did not have brain abnormality, I would have pulled. We would have pulled. All of us would have pulled. But here, important thing is HIV is not a static process. Insult has happened, but it will progress. So don't leave these babies and then just walk away. Right? You have to periodically keep examining because of its dynamicity, it will keep worsening. If it does, then obviously you are obliged to pull the baby. Yes. Right? Very simple structure. Essence of it. Essence of it. So full workup finished in 5 days and then sent the baby to So these are the sort of the dilemma that we get, right, in terms of this diagnosis. So basically, we take over. So another case which was referred, some part I will just put it because it cannot be the truth. Okay, just to fit the scenario here. So this lady was referred to a place, and they had 4 babies died in the past, and this baby had a cesarean section, baby boy, beautiful 4 kg baby. and did not cry after birth. And was resuscitated for about 5 minutes, started crying, got good spontaneous breathing, but definitely was encephalopathetic. Within half an hour to 45 minutes, started having deep going convulsions. And when they checked, so this, let's build it. What would we do? Correct. All of them died within the first 2 days. One died first day, second, like that. So no history at all about the baby. This is not unknown, right? This is how it will be in majority of the cases. So there is a sentinel event. The baby did not cry. Sentinel event was not known, but the baby did not cry. Then seizures within 1 hour. Yeah, that test showed acidosis 7.1, base excess of -18. What other investigations do you want to do immediately? Blood sugar was undetectable. But you still cool? Baby also didn't cry at birth. Yeah. Because the seizure lasted for about 5 minutes, they had given phenobarbital. In the biological status, the suspension is very different. Go on. So, Dr. Suresh, would you like to come in? What are the other possibilities that you consider? Okay, that is based on that history. No, she was very healthy. She was very healthy. So ammonia lactate. So you want to go for a metabolic hypothermia. Okay. What about the hypoglycemia? It can also happen. Yeah, it is persistent. Like galactemia and other topics. So we will get it close to the So and add two things. First question was very cool. As we Dr. Pratap said, it's 1 hour delivers areas from there. I would like to make some corrections to that. Probably 3/4 segment depths, disturb spontaneity, more work counting us for a persistent hypoglycemia, metabolic cost of cooling food can be delayed for 2 to 3 years because up to 4 hours is acceptable for me or our regarding the persistent hypoglycemia, I would be interested to know till what GIR we do to maintain the normal sugar levels over the next 2 or 3 hours. So your GIR has reached almost 12 by 3 hours. Exactly. I was about to say that because your statement was unirreversible sugar test or at 1 hour plus, which was very alarming for me because of such a very unlikely that could have happened. I would expect to have hyperglycemia rather than hypoglycemia because of the stress factor. Or can be hypoglycemic, but more or it's hyperglycemic. And subsequently, as you said, it's 12 mg per kg per minute, but within 2 to 3 years, even then we are not able to maintain a sugar of 45 milligrams per deciliter, which is operational threshold. Then I would think in terms of resistant hypoglycemia and escalate my management in terms of understanding the process. I would like to send for critical samples, including cortisol and growth hormone. I will draw those bloods along with the central and biochemical. And subsequently, I will do for urine sequence and reducing substance immediately, which is just like a side lab process. It will be easy for me to understand galactosine and which said if either of them are positive. Moreover, what we have seen is organic epidemias or anything with protein epidemia, they do easily pick up once we start to. And this probably you have to see where you will take place. Exactly. So you have got your MCADs as well. Yeah. Along with that. So where the death is very common within the first 1 to 2 days of life. So then basically we did not fool this way because we thought this is basically something very different to what it is. And it became so resistant. And just to tell you, we went on to glucagon, octreotide, and obviously diazoxide, and we were on 20% of glucose infusion. And on top of it, I'm going day 2, day 3, we were on sirolimus. So in spite of all that, we were still not able to maintain the sugar levels. And we wanted to go for a DOPA scan. At that time, the baby arrested and had severe sepsis by then because of significant suppression from the sirolimus, and it died. So we had sent for genetics, clinical electron sequencing, and that came as A1CC gene. So very sorry to drag it in there, but I'm just trying to tell you guys how many surprises are there in store for us, in these sort of things. Ravi, are you still there?
Yeah.
So Ravi, I just want to get your insight because this is a different crowd as well. Last time we had discussed about the Felix trial outcome.
Yeah.
I wanted to give us the idea about what you guys are doing. What is your message? Are you in compliance with what NNF has given the position statement? Because
Yeah, I mean, so that is what I was telling in the last time as well, because it's just the population. You just need to look on the population whom you want to cool and whom you don't want to cool. So be stringent in the criteria when you want to cool. And I completely agree with the NNF guidelines. So that should be correct. Now the focus should be on preventing HI, and that is what should be our next step. So that is what our focus has always been now. That's the prevent trial all about. But otherwise, for now, I'm sorry I missed most of the interaction, but I'm sure you would have covered it. And so, is there anything specifically you wanted? Pratap, you guys there? I lost you.
I think the connection is, it's me, Rojo, over here. The connection is getting poor, I think.
Okay, no problem. Okay.
Is the audio clear to you?
Yeah, I can hear you guys. But I don't know what you got.
Yeah. Ravi sir, can I ask my question?
Yeah, sure. Ask me.
Yeah, nothing. I just went through the trial. This one. They said that you guys found the history of GI bleed was quite common, and that was directly proportional to the number of deaths as a secondary outcome.
Yeah.
Gastrointestinal bleed, sir.
Correct.
What was the observation like, sir? Because I could not understand that statement very
so you mean why the GI bleeds were high? Is that your
Was that a particular observation you guys were looking at, or it was an incidental finding?
It was an incidental finding because we thought there will be thrombocytopenia because whenever you cool, one of the two important things was the sepsis risk is high and platelets will drop. So we knew that there will be thrombocytopenia. So that means it can manifest as bleeding. So where bleeding happens, we were just out of the blue and we saw that there was a good amount of GI bleed. So that is the only incidental observation we picked up.
Was it proportional to the death, sir? Because Mangalwati sir made a statement in the morning that the secondary outcome what sir observed death prior to discharge proportional to the GI bleeds what they saw. They had to stop cooling in between certain centers.
It was not proportional to death, but it was most commonly seen in babies who died. They all had GI bleeding. So it's not a cause and effect, but it may be an incidental observation.
And the effective requirement might have been quite helpful.
What was about FFP? I could not hear about FFP. What did you say?
Might be quite helpful.
Platelet transfusion might be provided.
No. FFP, 5,000 plasma.
FFP was given, you mean in this Helix trial?
Yeah.
Yeah, I mean, not everyone got because, we did in public sector. So where you get FFP in many cases. So where it was feasible, we managed, I think. But not all of them got FFPs, if I remember.
Sorry to interrupt. I'm Dr. Ojo here. I just want a small... Hello? Can you hear me?
Yes. Please tell me.
Yeah. Only one thing is only one thing that happens during HI, during cooling is that the platelet function will be altered. So you may have to transfuse even when sometimes the platelet count it goes below less than sometimes around 1.5 if they have evidence of bleeding. Because the function of the platelets may get affected in the time of cooling. That's what the Western literature says. So conventionally, we say less than 1 lakh an instance of bleeding is there, we'll have to transfuse. But in case of hypothermia, you may have to transfuse it less than 1.5 even if they have an instance of bleeding, because the function of the platelets may get affected. So what was your platelet count in those scenarios? What was less than that particular range, or what was the reason for that excessive GI bleeding? Because of a coagulation problem or because of platelet function problem or something else?
So we thought it was more of the thrombocytopenia rather than the function. We had thrombocytopenia.
Was there thrombocytopenia at the time of randomization, or you noted thrombocytopenia?
No, not
after...
randomization. Not randomization. It was not a criteria at all.
Was noted only after starting treatment.
Yes, exactly. Yeah.
Okay, and was that thrombocytopenia seen only in the babies who are cooled, or not seen in other babies?
We saw mostly in the cooled babies. I don't know if you've seen the Helix paper, but the annexure, if you go through annexures, you look through those things.
Yeah, I saw that. The only thing is it's quite interesting to say that because the GI bleeding, we have done so many coolings that GI bleeding was totally rare. That's why I was asking that. So, okay, thank you for the information.
Welcome, man. Welcome.
The GI bleeding was associated mostly with thrombocytopenia, and in those cases, the mortality was more. I don't think that is the case with us. We have seen more than 100 now. I don't think we have seen that many GI bleeds and that's significant. One more thing we didn't discuss about the Helix was how many babies who are moderately encephalopathic died. So I think that number is also quite significant in the Helix trial. Usually, in centers where you are more experienced in dealing with good sick babies, so you don't see that many deaths in moderate encephalopathy. What do you think, sir? Roger, you want to comment? Yeah. Usually, moderate encephalopathy very rare to get they may have some sort of developmental going to the death, they are not. But once you make that even since you withdraw there are less chance of going to. In some cases in UK where the had to go for, the court to withdraw the case. The parents are not agreeing to withdraw the case. It used to be like that. We have seen two scenarios like this. Okay, fantastic. So, you want to take this next question? There's a term baby delivered by LSS because of previous LSS. And then it's cord around the neck was noted. And then the baby did not cry immediately after that. There's a good center which did a cord. Gas as well, 6.9 pH, basic system, -17. Would you start cooling this baby just on that criteria, or you do anything else? The baby did not cry after birth, needed ventilator support. We continue to ventilate, and then the baby is getting better. But then the blood gas was severe acidosis. What is the next thing that you will do? Okay. Right. You mentioned about passive cooling. Is it really necessary if you are a cooling center, the baby is born in your labor ward? Is it still necessary to do that passive cooling? So not necessary, but it is actually born in the okay. I know. I mean, Dhanlakshmi has been trained in UK and then he came here. There are a lot of units who are very, very confident that this is HIV. They will just switch off the water. So I would say, suggest in India, we should not advocate that. We should do according to the NRP guidelines for resuscitation. You've got ample amount of time later. You would have resuscitated 15 minutes, 20 minutes. If going more than that, obviously you would have stopped the treatment, and then you get the baby to the NICU. You've got good time to assess. You're still very early, so you can still start active cooling. What happens in India is a lot of people will just keep switching off the warmer without having the hot knowledge. Then I think that will be more detrimental. So let's give the message saying resuscitation should happen with NRP guidelines and under the water. Right? So now you came to the unit, you assess the encephalopathy. And the baby, you think it's moderate encephalopathy. Would you cool the baby? You would cool the baby. So, Dr. Suresh, very difficult questions are for Dr. Suresh. Okay. So basically, you decide to cool. It is very, very obvious. It's a very obvious case. You want to cool and it improves the outcome. But here, when you're talking to the parents, they don't want you to cool the baby. That's it. How do you manage this?
And hopefully this is a scenario with the past experience of our unit in working in open and it could be the national therapy care. So the second option is, say for example, I will tell you talk to them at the experience what happens with the whole food and what the food is stopped further and then continue.
Right. So you talk to the gynecologist. She doesn't want you to do it.
No, but the ball is in my court here. I have to take a decision. I have to be firm and not just lead to her pleasure at all at this point of time. I would still go ahead with the training, but it's my, I would probably document and I would take the training. And things to be realized.
Yeah. Is there an option where you can just tell parents, obviously you decided not to do it, you may in writing, and I will not do it.
Now, there are two ways of talking to this. First, what is your understanding of what your program is very important? Because I believe that particular time and then you want to put that saying that what is truly is not what. That's my mistake. Probably more two positions to take into consideration and take the consent from them. One is explain to them in their own language first, and probably
Do you think taking signature is more important or taking the baby more?
taking the baby is first and foremost important. I would say
No, they're not consented. Are there any other options available now?
I mean, if they're not consented for schooling, but here I would have a baby this time, I mean, just 2 years or no 2 years, but still the baby is not schooling. Yes. But I would still keep it on a plastic schooling.
Why would you do that? You have to take consent for that as well.
Yeah, but I would still take this because it's a pension center.
But you still have time.
Yeah, it's a still, I mean, it's a pension center, I would still take it for both. But the other thing is, when you have a consent, you have to go to the court of law.
Okay, that's probably it's a bit
More on the part.
yeah. Would you not like to understand here what is the reason that they are so strongly going against it?
No, that's the reason I said, but what are the reviews? Why they don't want it? They are probably saying that's the reason. And then as I said, I probably explain to them what happens if you school and what happens if you don't school. And we give them the data, the national data, the international data, and all of this.
Good. I think the take-home message here is, in these acute scenarios, sometimes the obstetrician might not be with you because they are also very defensive. Everything was going well, something has happened, and then the baby is not crying. So they are defensive. You need to protect them as well. I'm not saying protect as in you're hiding something. You have to be as professional as you can be and be with them as well as them. Number two, majority of the majority of the times when parents are not willing for the treatment, the reason could be they don't have confidence with the treatment clinician, or they're in massive denial. Or like what Suraj is saying, there must be somebody from the medical background in the family. Right? They would be when the contacted, they said, no, don't do it, you know, I've seen the heat, something like that. People will be giving them the product. At that point in time, if you know that there's a doctor in the family, what else do you do?
Yeah, then speak to the guy, before the
so that is the take-home message. So try various methods. See, at the end of the day, even if there is a colleague who is actually causing a lot of problems to you during the working time, don't come and find, or always testing you, always doesn't listen to you. They have their own whims and fancies of doing things. This all comes into the difficult colleagues. Similarly, these are parents who are different parents. So what happens is the victim is difficult colleague is one person who is usually in difficulty themselves. Don't go to their shoes and then wear their shoes. You won't know what is the problem. Right? So you have to not just be angry all the time against the parents, not be angry. You have to go to their shoes and find out what is the reason that they are so much against him. Right? So one last scenario we'll do, wherein we'll take the journey of this baby. Ram, you can start. Rojo, are you still there?
Yes, sir.
Okay, Rojo, you can start. So this baby he's been started schooling because he fitted all the criteria for schooling, right? So I would give you a scenario where this baby has got refractory seizures. How do you manage?
Okay. The first thing,
levetiracetam, and then basically seizures are continuing. So you build the case.
okay, sir. The first thing for any baby who's seizuring in an ICU is to first check the blood glucose and see whether it's hypoglycemia is there or not. Because if hypoglycemia is there, it's entirely different story. And if hypoglycemia is not there and the child is still seizuring, always as if I mentioned, if I heard clearly, if I loaded levetiracetam, but I still think I still think phenobarbital is the best choice anti-epileptic in neonatal seizures, even though the There's no evidence to say that levetiracetam holds benefit over phenobarbital. I think levetiracetam in controlling 20 mg per kg phenobarbital and see whether the child is still stationary or not. If still stationary, just consider another 5 mg per kg loading and go up to another 5 mg per kg and go up to maximum of 30. Still considering seizures, if there are any other anomalies which is leading to the seizures, like say you had a child with encephalopathy, doesn't mean that always it's HI. Maybe because of some neuromuscular disorders which would have led to the neonatal encephalopathy. So we have to look up what something else is there, what some structural problems is there inside the brain that is responsible for the refractory seizures. And if still even these things are all ruled out, I would like to start off midazolam infusion as my resort, and that would be my plan of action, if provided all the electrolytes, say the calcium, magnesium, or all these things are on the normal levels.
So yeah, all of that is done, and your EEG technician is coming to start the EEG now. So EEG is still showing status epilepticus or continued seizure activity. What would you do? Are there any other options? And we've done the ultrasound of the brain, it doesn't look, that abnormal, apart from having significant cerebral edema.
Okay. So we are given Levipil, we are given phenobarbital, and then we can still try fosphenytoin, sir. If it's still seizure, we can still try fosphenytoin. I don't think phenytoin would be a good option. Fosphenytoin would be a better option if still the child is seizing, because reasonably produced selectron is in phenytoin. Even if the midazolam infusion, maybe around 5 to 15 micrograms, from 5 micrograms and go up to 15 micrograms if it's needed. And most probably with this, the child should be controlled, or else one can try the newer anti-epileptics. The problem is that topiramate is available only orally, may not be useful, may not be, IV preparations are not available. So you may not be able to give it oral in this particular case.
Okay, fine.
And there are some centers, a center which still used to use valproate after examining. Personally, valproate should be used in this newborn case.
Okay, fine. Dr. Deepak, you wanted to add some more to it, that thought process of what would you do? EEG is present, still showing seizure activity. But if you could give either option, I would definitely to involve how EEG was doing that when the doctor is and then block. Okay. So that's what I was doing into Roger, just going up and up in terms of the difficulties. So then the same way we also have metronome acceleration, and we are struggling with the saturation. And your echo person did the echo, and then there is a very significant pulmonary hypertension. So how would you manage this pulmonary hypertension? And what are the important components that you take to decide what is the next further step of function?
Sir, one.
Roger, this is a question for Ram.
Oh, sorry, sir. I could not. The voice is not clear. The audio is not clear. Sorry, sir.
This is Dr. Ram. So
basically, we take boy into consideration.
Just for the sake of people present here, what is OI? How do you
protein and look at the X-ray is bad. Less than
So your center, and you can start nitric oxide. So oxygenation index is about 18. So would you start nitric oxide with that time? Good. So then obviously, before starting the nitric oxide, did you do anything with your blood pressure? So your systemic blood pressure was slightly on the lower side. I would like to, I know it's not a hemodynamic workshop. I would like you to add a couple of things about the choice of your inotropes.
Basically, depending upon the child had acids, a lot of seizures are there. There will be dysfunction is there.
There is a dysfunction.
Is there. And what about your systolic and diastolic blood pressure, which is slow. Systolic is slow. So you can have essentially dopamine. Dopamine is dopamine is the systolic blood pressure. So sometimes a lot of public hypertension. So after pressing something to reduce both public hypertension and increase less BP. So ideally speaking, not
absolutely. Yeah. So especially if you are looking for a pressure effect in terms of shock because of your sepsis, which can be coexistent in this HIV disease. So probably I would start with noradrenaline and maybe add milrinone as an adjunct because of the energy function. So yeah. Majority of the studies where the drop has happened, there they have given it as a bolus, or what do you call it, loading dose. Loading dose followed by maintenance. So you like to avoid that loading dose. Then usually with noradrenaline on board, with the hypertension is lesser. Right? So Dr. Sharma,
Pradap sir, so can I? Sir, Pradap sir, can I add one more thing, sir?
Yes, yes, yes.
Sir, regarding the refractory seizures, I don't know what. One more thing is like I would like to consider IV pyridoxine if the child is still refractory to all this conventional anti-epileptics, because pyridoxine responsive seizures can be missed. And if you just give 100 milligram of pyridoxine IV and see whether the EEG is getting normalized even after all this conventional anti-epileptics has worked, it's not as being given, it's not working. I just want that point to get it. Thanks.
Absolutely. Thank you, Rojo. Thank you for that input. So now this same lady who's having fractal seizures, getting under control, then had primary hypertension, got onto nitric, started to have some GI bleed, and you know your LFT is back. You know the SGOT is about 700, SGPT is about 400, right? You think this could be sepsis related, HIE related, going into DIC kind of a picture? So what are your surrogate markers of liver injury? There's a gastric bleed. So you transfer the better field. In your units, for some reason, you've done fibrinogen as well. Fibrinogen is 0.1. That's quite low. So would you consider anything else? So yeah, it's been 6 hours, so you've been reading.
little bit of blood is noted from the lungs as well. So would you consider stopping cooling in this area? It's about 6 to 8 hours now. So I think you have given amikation as your first line. Then you're scared that the CRP or any other disinfection markers that you high and the baby is infected. You started on meropenem and cholesterol. Obviously, renal dose you have got and then given. So this has definitely resulted in a renal shutdown. And your nerves at around 14 hours of age tells you, Dr. Sidhu, I didn't get any urine output for the last 8 hours. Are you worried about it, or are you concerned with what is your next step? This is the same baby who's on nitrate, who got bad seizures, and who's in possible GIC. And you worry about it, there is the baby is still in the origin phase. What we definitely do is based on the natural course of the baby. And if you are in the origin phase and the baby over a period of time, maybe the baby is died. The baby has got a renal shutdown and the fact that you are so that unit was about ultrasound, they looked in the bladder as well. So you have to do basically to look at any other structural abnormality. Bladder, which makes the approval of any component of hydroelectron cystitis for that matter. We go at the creatinine level, which we use for all training babies on the creatinine is 1.1, which was done at the time. Okay, you waited for 2 hours, your PG calls you exactly at 2 a.m. in the morning. Right, so the gas is still acidotic, lactates are about 13, and still no urine output, and the potassium is 7.5. And on the condition. There is a renal shutdown with high potassium. Definitely, I think about reducing potassium and without would make a bigger potassium difference, not 10%. In spite of that, it is very wait and watch because I want to at least 3 samples on my. But it's an arterial sample. How else would you try to reduce this hypothermia? Are you worried the next 2 hours later, you ask your other patients, 2 hours later, there is still no urine, and then the potassium is 8.3. Calcium is all right. You will not want to do it. If it was 7, after 1 hour, it's 8.3. But I would wait for 6 hours to see if there is no urine. Ram, would you do anything different? Even before doing feeding, would you like to do anything else? Here's my challenge. Would you like to do that?
lose anything. This is what the debate is. Are we going to be yeah. Yeah. So the volume is okay. The volume is all right. Yeah. If volume is all right, if there is no feature, definitely. If there is a component of LV disconnecting, you are not solving on. No, and this is on the blood gas machine. Yeah, exactly. That is not it. And we have to put that definitely as massive tank provided everything else is on there. And PD also, I think hardly we have done. PD is fully heavy. Not right. But this scenario has not come. Definitely, yes. Then also PD of bonus with elastic challenge to the area. We'll look for again with also. Even 5 to 10 ml of Indian pumps, that would be a good response. So at least PD is up. So until then, you protect your cardiac and then wait and watch. All agree with that. Anything else you might be different? Yeah. So good. You have to bypass this. But that's the only. That was a great lesson. That was a great lesson. Because if I say bypass, this is absolutely. Yeah, absolutely. The production is very high. And you have why do you exercise? You don't use that. How much you do? Anything else would you like to add? How sick is this baby? That's the question is not to be. Listen. We have the current pandemic scenario definitely. Absolutely right. So it can present like anything. Like we have seen. I totally agree. Yeah. So then you're talking to the parent. You're talking in the morning. Quite ominous. Everybody talking about that. So how would you basically put it across? At that time, your PG comes back and says, the 15 ml which is come out. Is that change? That is the most important thing. In these circumstances, you don't have one discussion and then when the baby is almost dying, you don't have the second discussion. So whenever you see that it's deteriorated, keep having this. That communication should be documented and if possible recorded as well. Right? So the next morning you see this baby, lactate is about 17. Would that change anything? 13 to 17. And then how do you prognosticate? They want you to do everything. What is the information you're going to give them? If you continue everything and if you do that. So why I suggested about the lactate is when you look at audit investment, very long term, also taking into account about 5 years worth of lactate data, there are no survivors when the lactate goes above 15. There's no survivors. So 10 to 15 lactates resulted in moderate to severe disability, unless it got corrected very quickly. So an acute brief episode of asphyxia, your lactate is risen up, and then the baby started getting better, and you're okay with minimal time, and then cooling your time. That's the difference in it. Otherwise, majority of these babies ended up with moderate to severe disability. Therefore, you keep looking at the lactate 12 to 24 hours. If it starts coming down less than 10, be more confident. If it is still on the higher side or keep going up, then I would say very cautious in giving the presentation. Any questions? Anybody? I think I've run out of questions. I think we discussed everything in detail. Neuro. Yeah, probably. I put it up. Scenario. I'll take time. Maybe 1 to RFP. Maybe was what when you were around. Another is only maybe weight was and then our supply this is how do you use product and manage irrespective to respective will not go in the sense whether it was ventilated or not ventilated. Regarding hypothermia, how do we do? I think most of us should have come up with none of them will be like our expectation or TV in contact. When you have your wrappers around. And we are basic rule of therapeutic hypothermia that is not. Because when you do the country that's the second area amount. This idea is not going to cover the funding. Probably it will take longer for the bilirubin to come down rather than not working at all. That's the kind of work we have to do. What is the total volume in the exactly. No, I mean, you release it if you didn't have to do it. Speaking about a moderate to severe disability, they are not able to, where you can't be literally on the such scenario. Where the women is also an issue. Yes. I think it's complicating the matter even further. So just one last question somebody asked us. In this baby, how do you monitor the rectal temperature if it is born with imperforate anus? So cool. You don't want to? That chin is beautiful surprise. Right. Is this a treatable congenital malformation or not? What about the esophageal probe? We can do it, but as you rightly said, if you go by book or law, because not, then now what's on the future? Definitely, it's absolutely difficult to do. And it depends on the parents' consent and just. No, the answer is just such an unfortunate thing. So with that, I think we should just wrap it up. Thank you very much. I would like to thank NNF India and NNF Karnataka for giving us this opportunity to, to host this workshop on neurophysical care and therapeutic hypothermia. And I would like to thank all the panelists, all the delegates who've come in here today, and all the the manufacturing companies, people, the managing directors, everybody, providing the equipment and giving us the knowledge on what is coming up, in the near future. Thank you very much, and I'll be training in my duty about thank you. Thank you all.
ಮುಗಿದಾನೆ ಇಲ್ಲೂ ಮುಗಿತು ಬಸರಪ್ಪ ಹೋಗ್ಬಿಡ್ಲ ಜೂನ್ ಲಾಗಿ ಟ್ರೈನ್ ಇಲ್ಲ ತಾನೆ ಜೂನ್ ಲಾಗತ್ ಟ್ರೈನ್ ಇಲ್ಲ ತಾನೆ ಲಾಸ್ಟ್ ಮಾಡ್ತೀವಿ ಲಾಸ್ಟ್ ಆಯ್ತಾ
Thank you.